questions whilst we're going through. But you will get to see us doing our business in a transparent way. So that's the point of the meeting. For everybody who is participating in the meeting as members and attendees, can I ask, so whether you're in the room or online, can I ask, I know it can be really difficult sometimes because we've all got busy day jobs, but could we just give our attention to the meeting as much as we can? And particularly for people online, if you do, for any reason, need to take a call, can you switch your cameras off? Because it's quite destructive for other people seeing somebody sitting on their phone and taking a call. So if we could just be like, keep our minds in the meeting, at least for this first part, that would be really helpful. We have got various apologies, which I'll work through. We've got a member of public in the room, so I might come to you first to just introduce yourself really quickly. Is that possible?
Well, I'm Michael Taylor, a company called HBS UK. We provide digital patients, and also we do insourcing.
Thank you very much, Michael. And then we've got apologies from Matthew Bryant, who's the CEO of Dorset Healthcare and Dorset County Hospital, Sam Crowe, the Director of Public Health at Dorset and BCP Councils, Paul Johnson, who's the ICB Chief Medical Officer, Rachel Pearce, who's the Director of Commissioning for NHS England South West, and she's actually our link into the South West region, and John Sloper as the Interim Programme Director, and Jim Andrews. Patricia, Chief Executive, is back, so welcome back, Patricia. I think this might be your first meeting in public, so welcome back. And thank you very much. And David is in the room, so I think David will still cover off your report if that's okay, but you're around to answer questions online if you want to do that. And then Dean, I think you need to step out at some point, don't you? So 12:30. Thank you very much. Okay, so unless there's anything else, I'd like to get us started. I guess the first thing I wanted to say is that this is our first meeting in public since we ended the 23-24 financial and operational year. And I suspect everybody in the room that memories of quite a difficult year for many reasons, really. Financial stresses right across the system, some performance stresses right across the system. So whether that's around getting packages of care, speech and language therapy, around access to hospital treatment, there are lots of things that the system is stressed under. And of course, we had various forms of industrial action over the year. So despite all of that, I think you'll see from the papers as we go through, we managed to come through as a system fairly well. It does mean that we've got another difficult year for 24-25, and certainly as an integrated care board, for the health provision part of the integrated care systems, we are still in the process of negotiating and setting down our plans for this year, for the 24-25 year. Ideally, we would not want to be in May, second month of the year, doing that, but as the financial agreement for the NHS got signed off at the nth hour, that's where we are. So, so please bear with us whilst we still do that. You will have some papers that show where we have ended collectively for 23-24, some of the challenges that we have for 24-25. But I think the thing that I really want to draw on is, despite all of the challenges, we have managed to deliver some really good work. And we know that this is going to be an optimum year for us to deliver against our 5-year plan. So as difficult as some of the months ahead might seem, let's please keep focused as a system working together towards that end goal, because if we can do that, we can really deliver for our communities. So we are quorate, so we'll move into the meeting. Can I just ask if there are any declarations of interest? John.
Yeah, thank you, Jenny. In Patricia's report in 2.3, she will talk about the CAS review, and it references that a new service has been set up, one in the north and one in London. in my day job, I'm an exec at Great Ormond Street Hospital, who is hosting the service. So I just wanted to make that point
Thank you very much.
transparently here.
Thank you. And a reminder to turn the mics on when we're speaking, so I can hear you, but just a reminder to everyone to put microphones on. Any other declarations of interest? Okay. Let's proceed then. So we'll start with the minutes of the last meeting, which was held on the 7th of March, so just before we got to the end of the financial year. As we are meeting in public, I will turn the pages. So starting from page 2, can I check if people want to raise anything from those minutes? Page 3, page 4, page 5, 6, 7, 8, 9, 10 and 11. But I will take that, the absence of any comments as an accurate reflection of the last meeting. So thank you very much. And then moving to the actions, all of the actions have been completed, so I won't dwell there. So that then takes us into the board story, which I think, Debbie, you're going to kick us off on.
Thank you, Chair. Thanks, everyone. So good morning. We're going to actually present today a piece of work that my team has been leading on called the Hydration Project. I'm here today with Tina Arnold over there with the lanyard on, who's my head of infection prevention control for the ICB, and she's joined today by Vanessa Howard, who's one of our care home managers. They're both very nervous, so I told them not to be. I told them we're all very nice and they need to be nervous. So what we're proposing to do is to just show you an 8-minute video, which actually takes you through the work that we've been doing, and then I'll hand over to Tina, who will just talk to you for a few minutes, and then we're going to answer some questions if that's okay. So,
Great.
So I'm hoping that James is going to just seamlessly move into the video now. Thank you.
So the hydration campaign is part of the antimicrobial stewardship and as part of the AMR National Ambition Plan to reduce healthcare-associated infections and to reduce the antimicrobial resistance. And we all know that hydration is pivotal for all humans to stay alive, and every single cell, every tissue and every organ in our body need to be hydrated to function effectively. And I think it's really important, especially when we get older, because the ability to have a reduced thirst reflex and loss of function in your kidneys, which actually can affect the ability to retain water in your body. So it's really important to keep hydrated, particularly when you get older. And of course this can lead to increased risk of infections such as urinary tract infections, but also increased risk of falls and unfortunately admissions to the hospitals, which can be very unpleasant. So to really improve the health and the overall quality of life, we've got a multidisciplinary hydration team consisting of specialists across the Dorset, and we actually co-design a number of educational resources around the importance of hydration and its benefits. And we've been very privileged to be able to try our first pilots in a number of care homes and at University Hospital Dorset, and particularly here in Adams Court Care Home.
So Tina came to us and she asked for a variety of different touch points in the campaign. So we made a whole suite of resources. Some of them were patient leaflets, some of them were pull-up banners, and some of them were a little bit more fun, like the tabards. So we've got people wheeling around hydration trolleys, and they've got the graphics on their tabards, so it just reinforces the messages that are in the campaign. The thinking behind How Do You Like Your Cup that came about because we had some insight that a lot of times patients don't actually drink their cup of tea, and it might just be something as simple as they haven't been asked how they like it, they haven't been asked how many sugars they like, they haven't been asked if they like it with milk, or they haven't been asked how hot they like it, or even if they like tea at all. It might be that there's another drink. So yeah, we decided to run with that because it starts the conversation and encourages a little bit of social interaction.
I was really enthused about it. I think hydration is really important, and I felt we were really good in both homes on hydration, but I thought we could be better. And it's such a simple thing to bring on board, and anybody can improve their hydration very simply. But we wanted to make it fun for the homes as well, so we've introduced a lot of different aspects around hydration. I just thought it was really easy. It was a really easy thing to do to improve the lives of residents. We run a hydration round twice a day. That's on top of the tea and coffee trolley and the afternoon cake trolley. So we run one about 11:30 and then about 7 p.m. So on that trolley is juices, hot drinks if they want it, different types of hot drinks as well, not just tea and coffee, Ovaltine, Horlicks, all of those things that our residents in their age group will remember. Coke floats have made a huge comeback, so they absolutely love Coke floats here. And I'm not going to worry about the sugar. You know, when our residents are living with dementia and are of an older age bracket, they can have exactly what they like. Smoothies, anything, milkshakes. Moving on from that, they made fruit skewers, jellies, jelly shots. Our chef has made little jelly shots so they don't have to have a whole big jelly. And also introduced mini hand blenders. So they just make one smoothie. And the care staff can literally take the trolley to the resident with all the different types of fruit and creams, ice creams, different flavours of milk, and say, what would you like today? And they can pick it themselves, put it into the blender, make their own, if they're just battery operated blenders, make their own smoothie. So it's almost like an activity as well, but they really love getting involved in that and choosing what they want to have. It's made a big difference. The impact on the residents has been huge. It's been phenomenal. So we've reduced our urine infections, our UTIs, we've reduced our falls. The residents are just seem healthier and happier. There's been a marked difference in their sleeping patterns, they're sleeping better, and their engagement. So their engagement with activities, with each other, with staff, we've seen an improvement across the board in all of those aspects.
Yeah, well, when Pat came in, because she's got vascular dementia, so we were told that there is nothing you can do for that, no medication or anything, so she'll gradually go downhill. But she was quite talkative when she first came in, but as time went by, she got more into herself, but there would be times when she would have what they call a chatty day. And when she did, what they did was phone me up and said, Pat's having a chatty day, do you want to come in? So, all they asked of me was, would I tell them how much she's drinking while I was in? So when I come in, when they come round with a cup of tea or coffee, I give it to her. And I'm also giving her water to drink. And I would just say how many glasses of water she's drank. Did she drink all her tea or coffee? And I'll tell them how much of that she drank. And that was they were quite happy for that information. But I would say it's benefited that because you can see her skin's good, you know, through the hydration.
So the knock-on effect for staff has been a calmer, more peaceful working space, I suppose, for them. It's a stressful job. It's not going to be a stressful job. But I think they're engaging much better with the residents. So they're getting benefit. Also for families, they're engaging much better. We've made them all aware of the hydration project through the leaflets, through the posters that are up in the home, talking it through with them. We made it part of our residents and families meeting. So just to get the message out, it's also become a bit of an activity for them. It can be very hard. People do think, you know, when they come to visit, they have to stay for at least an hour and they must take part in something, but it can be really hard sitting with someone for an hour that is not verbal and can't give you any feedback. Whereas being part of this, you know, the hydration trolley can go into the room or we can make up a tray. they make them smoothies, it opens up some conversation and they feel they've had a more productive visit, I think, you know, and that's the feedback we've been given, certainly. And that goes with the staff as well. You're in this job because you want to care for people, and when you see the people you're caring for in a happier mood, being healthier, it makes your job so much better.
Thank you. I'm going to hand over to Tina now. I will just say apologies. I don't think people could hear that online, but actually the subtitles were there. So hopefully, if you couldn't hear properly, you could still see what was being said. So I'll hand back to Tina now. Thank you.
Lovely, thank you. And thank you so much for inviting us here today to be able to share with you about our system hydration project. And although the video really speaks for itself, I think it's really important if I just share with you how the hydration project actually came about, as it really underpins why and how it has been so successful. And it goes back to the initial discussions and the thoughts and ideas that were all done collectively with so many individuals and so many colleagues across the ICS. We had representation from acute trust colleagues, from community hospitals, primary care, ICB, private care providers, and then later on also Bournemouth University. And what we did, we actually went out to our patients and to our residents and to the staff, and we asked about their views, about their opinions, about their thoughts, and that really enabled us to develop the educational hydration resources that were truly based on co-design and co-production. And it is very often that perception from our patients and residents to staff will vary. So we knew that actually having their voices right at the beginning of this project was really pivotal. And I remember when Patricia once said, she said, when it comes to improving healthy lives of our communities, be courageous and be ambitious. And I think that's exactly what we did. We stated our aim, which was to improve the health and also to promote the importance of the hydration. And then in April last year, we actually piloted in 3 care homes and in 2 older people's wards at Bournemouth University Hospital Dorset. And straight away we could see improvements, and the feedback from the staff, from the relatives and from the patients and residents was really inspiring. So we didn't really want to just stop there. We were on a mission. And then later in October, we started our second pilot, and we extended to 5 additional care homes, 2 community wards at Shaftesbury Hospital, further wards at UHD and also Dorset County Hospital. And we already started to have conversations with the Mid Dorset PCN about how we can promote hydration in primary care. And I can honestly say that everyone has been really enthusiastic, and they all came up with some incredible initiatives and activities involving and engaging with their patients, relatives, staff, but also the relatives. And I think it really shows that hydration can and should be an enjoyable experience rather than seen as an additional task. And what we also have seen was a reduction in infections such as UTIs and also reduction in falls, which is really encouraging. And I think it's just grown from strength to strength, and care homes have been absolutely amazing, and they shared their initiative with other care homes. And when we did have a group discussion with the care staff, I think one of the main key learning came that education was the key. And we're really privileged to say that our hydration video is now being featured at Bournemouth University, and it's part of the seminars with a focus of hydration and nutrition for all the adult nurses, mental health, and children and young people's nursing students, which is really amazing. But I will stop there and I'll let Vanessa to share with you what the true impact was of the hydration project, and not just for their residents, but also the staff and the relatives too.
Thank you. So we were approached over a year ago to take part in the pilot scheme around hydration. We took this on board, and at the beginning there was some challenges because I'm a manager of a care home which have got dementia in, they always wanted to go straight to their teas and coffees. So we were trying to steer them away from just having tea and coffee all the time. We started this very, very small because any changes doesn't actually upsets dementia care. So we did it very small, and we started with flavoured tea first of all, but this did not go down at all well. So we started to think out of the box. So we started to bring in ice lollies and fresh fruit. We made the fresh fruit and the vegetables into kebabs for them, so they could try and make the little kebabs with all different fruits and vegetables. We did notice that the brighter the colour, the better it was for them. So we had to make sure that we were buying the brightest fruit and veg that we could find. We did also notice that a lot of the residents would always home in on the jellies, because we had all different coloured pots of jellies on the trolley, and they just loved that, as they were so colourful and very easy just to eat and slip down as well. One resident actually did ask for a Coke float, so we did bring this on board, and then it just spiraled out, so everybody wanted a Coke float. So we were buying quite a lot of Coke and ice cream. We also did a hydration party for the home, so we brought bunting and put it all around the home. We brought all the families in, all the residents, staff were all involved, and it was a whole day event, which that just went down so well. There was a lot of comments as well from the staff saying that they noticed that they weren't actually drinking enough when they were on a 12-hour shift in the care home. So I've now noticed that there is a lot of more juice bottles that are hanging around in the care home, and they're in the kitchen, that is great, because they weren't literally just drinking on their breaks. So we did notice a big impact of that. There has been some challenges along the way. The biggest one was, as I say, was to steer away from the tea and coffee. Because there is so much out there. We didn't realise how many different ways you could hydrate yourself until we actually started the programme. All the staff loved taking part in the hydration programme. We're still doing the programme at the moment. We actually have the trolley goes out twice a day. The residents see the blue tabard on the staff member, and they know it's the hydration trolley, not just the tea and coffee trolley. So they know they're going to get extras. So that's what we've noticed as well. We actually noticed a very big drop in the amount of falls and the amount of UTIs, and we have not had a UTI in the care home since last December. I think that everyone that's in a care home or even in a hospital should actually take part and actually bring this on board into their own care homes. The staff have been able to adjust to their own personal lives and the ability to improve their health as well around hydration. To make it work, you have to work as a team. You can't actually just do this singly. So if you're not all on board, it won't work. So if you're just a couple of the staff, you have to have every single member of staff. We had all the activity coordinators on board. We had all the kitchen. We even had the domestic team on board, because they go into the rooms, so they will be able to help my residents as well. We actually have now made it as a activity on the activity weekly board. So they go and make all their different smoothies. We even make our own ice lollies and our own ice cream now. Thank you.
Thank you.
Thank you. I think we're just going to open up for questions now. Is that right, Tina, or did Jeff have something else?
Thank you.
So no, thank you both of you for presenting. I think it's always really helpful. Thank you. So I'll just open it up then.
Yeah, so let's go for questions. So Louise, I saw you put something in the chat. I'm not on the team, so I don't know if you're saying you wanted to come in or not. But I'll go to John first, and if you do, could you stick your hand up, because I can see your thing there. John.
Yeah. Such a great job. Thank you very much for taking us through it. And I really noticed a few things. I love the way the video started from, this is just fundamental to life. But then what I think I heard about was experimentation. You tried some things, and then you've had a real impact on outcomes. Outcomes, the UTI point that you made at the end was really profound. So I guess my question is, when we think about all the places in Dorset where well, thinking about from an NHS Dorset perspective, but more broadly. What would the next steps be to get this everywhere? Because it would feel like what you've done is you've trialled something and it's having real impact. Wasn't clear the extent to which this is now out there in Dorset in all of the environments that are similar to the one where you've done this trial.
Yeah, thank you. So I think it's part of the quality improvement process and a model of improvement. And we really wanted to trial, so this is why we just done a first pilot and then we extended to a second pilot, because the word about, you know, doing a hydration project just spread like a fire across Dorset. So we've been approached from so many different services. And now we actually got the evidence that is improving our health, it's reducing infections, UTIs, it's reducing the falls. And obviously, consequently, this has got a reduction in pressure on our health services. But I mean, most importantly, it's the outcome for the patients and better experience for them. The next step at the moment, we are evaluating all the data, because we've been collecting a lot of data in the past 12 months, with the view that the hydration resources will be shared, not just within a care homes and within acute community hospitals, but they also go into a primary care. And we've had first discussion with the Mid-Dorset PCN, and they started to utilise the leaflets to patients, particularly those who come to the surgery for UTIs, and then they're being shared and given the information. So our aim is really to make sure that everyone has got the same opportunity, but also those who are not attending their healthcare services.
Thank you. So Patricia, I've got you next, and then I've got Dan.
Hello, morning everyone. I'm sorry I'm not in the room. Got a bit of competing calendar events today. I just want to say, first of all, when anybody says Patricia said, I get a bit nervous.
Patricia, we can't hear you because we're just getting a loud noise.
Turn your mic on.
Oh.
Right, so I'm going to turn mine off and then try again.
Can you hear me now?
It's working on Teams.
So you can hear me on Teams, but you can't hear me in the room. We had the opposite at the NEDS meeting. They could see me and I couldn't see them.
Are you able to put something in the chat? Is there anybody that's on the Teams that put it in the chat? And then somebody here might be able to pick it up for you, Patricia. And
Yeah.
Can we get somebody to try and sort out the tech? Thank you. So I've got Dan and then Rhiannon and Dawn, and then we'll come back to you, Patricia, if somebody comes in to sort the tech out.
Thanks. Really interesting stuff. So thanks for presenting and talk about it. The trouble is when you do something successful, people want to kind of spread it far and wide really quickly. What I was thinking about during it was prevention and education. So this morning, trying to force a 6-year-old to drink his bottle of water. And so I was just interested if there are any plans to kind of get to a different demographic about the importance of this, especially when people are younger. So I was thinking about schools and education, and was just interested if there are plans to kind of broaden it out from the primary care network. But equally, this can't be everything to everyone all the time, because then you don't deliver anything. So I was just really thoughtful about children and education.
Yeah, and I think this is certainly a discussion we can have further. I think we're just doing a little baby steps at the moment. In terms of education for the staff, I've already started to have a conversation with the head of education across the ICS to make sure that it's going to be part of the preceptorships for newly qualified nurses and new staff coming to the acute and community hospitals, but also part of the mandatory training. But certainly in terms of children and messages going into school, that's something we can consider and have a further discussions.
Thank you, Rhiannon.
Yeah, thanks. Really well done, and great to hear that you've actually got data. So that didn't come out in the presentation. So having that as proper evidence in terms of the impact on outcomes really, really important. So I'll ask go in a slightly different direction, because kind of my question's probably been asked. So one of the things we're aware of is that staff themselves working in health and care often don't actually keep hydrated. I mean, we do hear of healthcare support workers and nurses in particular going long periods of time without actually having a drink, keeping hydrated. So I know in terms of the care home settings, we did hear about the staff getting involved, and that's great. I think it's it'd be helpful to hear how we're ensuring that staff are also getting hydrated in those acute settings as well. But I think all the other points that colleagues have made are very relevant as well.
So I'll just take another question and maybe you pick up at the same time. So let me go to Dawn.
And my point was very similar to Rhiannon's.
Mike.
My point was very similar to Rhiannon's about the opportunity you saw for staff hydration. Some time ago, there was a pilot at Birmingham Women's Hospital with in maternity, and through the education of staff around hydration, we saw reduction in sickness absence, UTIs, all the stuff that you've talked about. So yeah, I'd be really interested to understand your thinking about what more we could do there to educate staff right across the system.
Thank you. A lot of the feedback from the group discussion was that about the education being a key. And actually, as you know, a care staff at Adams School, when they were talking and going through the leaflets with their residents, they learned themselves and also their families as well. And I think, you know, having this replicated as a part of the mandatory training and through the, you know, educational work streams, that's certainly going to support the staff.
Thank you. And then I've got Debbie and Siobhan.
I was just going to come back, so I don't know if you want to come to me at the end.
Okay, yeah, so Siobhan.
Tina and Vanessa, lovely to meet you. I'm Siobhan. I'm
Hey,
Chief
Siobhan.
Exec at University Hospitals Dorset. And just actually, you know, firstly, it's great to see IPC and IPC nursing out there and actually really working proactively and on prevention. So I just thought that was really, really great. From a UHD perspective, it's just made me, and from providers, it sort of really makes you reflect on what more we can do to embed this across the whole. You know, as nurses, it's sort of very much around basics. So, you know, I've got a new chief nurse, and actually I'll be telling her about your presentation and considering how we can embed it more broadly across the provider sector.
To Tina, I think Patricia's put her question in the chat, so I'll go to Liz to let us know what that question is.
It was a comment from Patricia. Patricia said, well done, everyone. This is a fantastic project and we can see the clear impact on communities. Can all parts of the health sector think carefully about how we can take on this approach? In hospitals, there are continual challenges around hydration and the link to fluid management and balance. And also, how do our engagement team take this and develop a much broader campaign in the community?
Great. So can I add my question to that, and then I'll bring Tina, Vanessa, and Debbie in to bring it to a close. So we heard the what, which was it's a hydration project. The so what has been that it's had a real impact, both in terms of staff being hydrated, but also reducing UTIs. I mean, amazing figures there for that home from December, and falls. So my so what was going to be, one of the things you mentioned was primary care, and we know that, you know, particularly for older population, often they can end up in hospital because they've contracted a UTI or they've had a fall. So I'm just wondering, you know, how do we get this into primary care so that we can actually do some of that prevention? I agree with what Dan was saying about broadening it out, but actually we've got a real focus here with the age group population that we have. So I just wonder, how can we move further into primary care so that people are doing this at home and getting encouragement from primary care, the voluntary sector, to move it there. And Ben looks like he wants to come in part to answer that maybe, or to ask another question. Ben, I'll go to you first.
Thank you. Well, I'd had a similar thought, and I suppose I was thinking
I'm really
around.
sorry, it's the same issue, so we can't hear you. We're just getting clicking noises.
Oh,
at
okay,
this
I'll
end.
put it in there.
Jane is out and she's trying to get the text sorted, so we will come back to you. So Tina, Vanessa, and Debbie.
I mean, I can come back to your comment, actually making it even wider. And I think that the whole point of doing a pilot is to actually show the evidence that it works. And I think this is why we started to work first with the Mid-Dorset PCN. And we've got a lead practice nurse in our hydration group. And actually one of our ideas was actually utilising the pharmacies as well in our communities, when actually people are coming for their medication and prescription, actually talking about the hydration and sharing the hydration leaflets with them as well.
Great, and Ben just said it might be a good idea to link into all of the PCNs. So that was the point he was going to make, I think.
Yeah, and we're also thinking actually going digital now as well. So we know a lot of primary care and general practices have got a TV screen in their waiting rooms. So our communication team's been absolutely fundamental with this hydration project and a campaign. And we do have a hydration website on Stable Dorset with all the infographics. So we are thinking of actually utilising those resources through the TV screens in primary care.
Thank you, Debbie.
Yeah, thank you. Thanks, Tina. And thanks, Martha. Just to sort of finish off, really. So I think thank you for coming. It's a really good project. So I think we can really see the evidence of it. I think sort of from a team's perspective, our discussion going forward now will be how we can sort of really launch next steps to make it as widespread as possible. I think I was thinking, have we, and if not, can we exhaust the voluntary sector options around spreading this wider, I think, and also local authority colleagues, and really sort of making sure that they're involved. Health visitors and school nurses around the points made around sort of the younger population, because I think sort of we could get this into nurseries, we could get this into schools, etc. And staff, as Dawn said, but we can't do that on our own. I've got one IPC nurse, she's sat here, Tina, and so in order to actually kind of make this work once you've done your evaluation, it really is going to be about sort of tapping into all of the resources we've got across the ICS and across the system. So thank you, and we will make sure that we really do that, and sort of just keep going whilst the enthusiasm is so sort of pronounced, really.
Thank you, Zoe.
Yeah, absolutely amazing. And it's resonated with lots of things that we do as well. So just going on from the voluntary sector, it would be amazing to be able to share video, share some of the comms and that sort of thing, and get it out wider through the digital format, and that could be done quite quickly from the voluntary sector side. So if you contact me, then that would be absolutely amazing.
So can I join Debbie in thanking both of you for coming along, sharing the video. It's always difficult when, because I saw the video before, it's always difficult to know how the video is going to touch you when you see it again in a kind of public forum, but it's got such a nice warm feeling to it. And I think what worked really well today was you bringing the additional information around the data and evidence that you've collected. So thank you very much for that. It also feels like a really simple thing to be doing, but actually has such a big impact, because what came across to me, both when I watched the video previously and then hearing you speak today, is that we're treating people as individuals. We're asking them what they want rather than as another person in the room. So well done for what you've done. You're obviously at the start, so carry on with that. And then anything more we can do as an ICB to support that, then please let us know. So thank you very much.
Thank you. Thank you.
And it's fine for you to leave, sorry. If you want to.
Yeah, feel free to leave.
Thank you so much.
That's fine. Okay, so that moves us on to the board assurance framework. And we specifically asked for this to come at the beginning of our agenda items, so that we can really think about our kind of strategic focus, what we're trying to do as an integrated care board and system, and then the framework that we're putting in place to make sure that we are assuring ourselves that we are delivering on those things. So that's why it's here. Neil, am I coming to you for this?
I wasn't expecting you to for this, but I'm quite happy.
Well, Debbie looked like she was poised.
Yeah, Debbie was.
But she's gone out the room.
Debbie was poised.
Yes.
Right. So it might be better because I know she's prepared.
Okay, I think she's just saying bye. So
yeah.
Is it okay now? So, Patricia or Ben, can one of you just talk to see if we've solved the problem, please?
Hello?
No. Has he gone?
Do we think we've solved the tech problem?
No, we can still hear you on Teams, but it's clearly not in the room.
Oh, that worked. Say something else.
Hello? Can you hear us?
Has he actually gone? Yeah, we just have to have a reset. Okay. Debbie, just.
Ah, now they've gone.
So, well, whilst we're sorting out the tech, and I'll leave you to sort between you who's doing it. Want me to get them to speak again?
Because I'm not, to be honest, I think.
Put your mic on.
I'm grateful for it coming back because it's something that's obviously very important and it's a work in evolution still. Had lots of feedbacks and comments on it, but I think from discussions, feedback, there's still some concern. We're not where we want to be on this important document. So the opportunity to have everybody feed into it, I'm not going to read through line for line what's there. I think it's probably better, unless people want me to open it up and to have the observations, the comments and the challenges in the discussion now, and then we can collect those, discuss them and take them back, because I'm not presenting it as a finished, it's all done and it's all perfect. That'd be work for the.
That's fine, and it's here for us to note, but we also wanted to use it moving forward to steer our business. So, so if we can think about it in that context in terms of any questions or comments that we have. To the floor, Siobhan.
Sorry, not waiting for the mic. Thanks, Neil, and it's good to hear that it's sort of work in progress, because I think we spend quite a lot of our time in providers looking at BAFs and risk registers and the interrelationship between the two. But when I read through this, I suppose one of the things that really struck me is that for Dorset, over the next 3 to 5 years, or actually over the next 18 months to 2 years, the risk is that actually we don't create care at home, closer to home. And I just, when I read these risks and how they were framed, they didn't really come at it from a person perspective. So I just, there was stuff around investment and moving it, you know, there were just, and actually I thought that actually as a system, we really need to enable a shift in the care models. And that is a big strategic risk if we don't. And that didn't really, it's in there, but it's not there from a person perspective. So I just thought that was really important.
So,
and the other bit was productivity. Obviously, there's a big shift and a big focus on productivity. And at the moment, that doesn't come out clearly enough in terms of the 5 core risks as described. And then just my final comment is, with risk appetite, I found that quite fascinating, and I don't know about everybody else, but you sort of rate where you might come at it from your sort of risk appetite. And I just wondered, have we had a development session or a seminar where we've discussed risk appetite between us? Because often that's quite critical in terms of where you land your BAF.
So I can answer the last one, because we did that. Had a couple of sessions as an ICB looking at risk appetites and moving this forward. So Neil, what I'm going to do is collect all of the responses, and then you might want to come in after that. So I've got Gillian next, then Rhiannon, then Dan, Rob and David.
Mine was a similar sort of general point about it as a tool, and as a tool for us as a board. My reflection on reading through it was that the risks that were being described and the risks were being described as out of tolerance felt quite significant, but some of the actions in there to mitigate it felt quite everyday activities. So I felt there was a bit of a gap from that sense of here is an intolerable risk against one of our really strategic goals. I think one was around sort of the partnership piece, which is maybe why I alighted on it. But the actions were kind of, we'll create a stakeholder map. Do you see what I mean? I just feel there's a bit of a gap in that action space. So either the tolerance is out or the action's out. And I think it's trying to draw to our attention what are those big actions that we need to drive forward.
Okay, before I go to Rhiannon, I think one of the themes that's coming out that you might want to capture, Neil, is that this appears to be confusion between the strategic risk register and the BAF. The BAF should be a different document, isn't it? So, and it might be because the document itself is combining the two. It's not quite clear. So you might just want to take that as a thing. So, Rhiannon.
Yeah, I'll get into the rhythm of putting the mic on. Yeah, thanks. And very well aware how this has sort of been gestating over quite a long period of time, and there has been workshops and discussions. And I think when those risks are described and crystallised, it is important that they sound really, really strategic and not corporate in nature. But I do understand to some degree what Siobhan's saying, and perhaps it's lost some of that kind of connectivity to the importance of that kind of partnership and landing the outcomes, etc. My key point, though, is in the BAF element, which requires the assurance, the key controls that are described. We have had conversations about this, certainly in the Risk and Audit Committee, that they don't appear as key controls. So I think to strengthen the assurance aspects of the BAF, we need to be having much stronger controls in the risks.
Are you happy for me to take some more, or do you want to talk about any of those? Okay, Dan, then Rob, David, John and Debbie.
Mine kind of builds, so I'll try to be additive rather than repeat what other people have said. I think this is a really good document, and I'm glad we've got it going, and we're kind of doing it in flight. I think is something that boards don't do enough of. But that distinction between strategic risk and BAF, I think, is getting lost in this. I think there's something about the risk management strategy which sets out how all these things talk to each other, and that might not be a board thing, it might be an audit committee thing, and I don't think we've seen that, and we need to. But the document for me is about how do we manage down the risk. I think what a BAF needs to tell the board is how do we assure ourselves that the controls that are in place to manage the risk are operating effectively, and where's that assurance coming from? And I think that gets lost in an 80-20 strategic risk register with a BAF on, and it's how do you pull those things out, accepting there'll be a Venn diagram between BAF, corporate and strategic. And so I think there's a bit more to do. I'd really like to help with that if I can, because these things get kind of quite introverted, but it's how do we assure ourselves that the controls are managing those risks rather than how do we get those risks down more. Thank you, Jenny.
Thank you, Rob.
Thanks, Jenny. So when I look at my risk number 4, I think that the strategic risk is the right thing that we've got there. But in trying to use this now, so it's a useful thing as opposed to it coming here for another conversation about what the document looks like, the design of the document. If I look at that now as that risk owner, I'm feeling, oh, I can't really update the board on what we're doing about that strategic risk. Everything in there is our BAU. It's your point, Gillian, that it's the actions and the mitigations of how we control the in-year of the money. The risk isn't about the in-year, it's about becoming sustainable and shifting to prevention. And what are we doing about that? And how am I telling you and assuring the board on that one? So, you know, my update on that one, and it's not even written down here, was just before this board meeting, I did phone up one of the folks I've got working on an outline draft financial strategy, short version that we can then pen all over the place and things like that. But we are starting on that piece of work, so we can bring that back to the board at time for a conversation about how we shift to prevention, etc., what that looks like, time to medium-term financial plan. But you wouldn't get that from how that's written at the moment. So I'm feeling slightly guilty as the owner of that risk now having designed and looked at that, it doesn't really kind of do it, which I think is just echoing what we've said on that. So for me, the financial risk, I'm going to read the bulk of it, all those bullet points, that's what we do anyway. But we're missing the bit about the partnership work with local authorities, how we're going to do that, how are we going to shift to prevention. You know, we had that great day yesterday with NHS as well around, you know, what the shifts look like. So that's my reflection. Let's just start using it. When you use it, it absolutely unpicks if it works or not.
Yeah. Do you want me to keep going now?
I think so, yeah, we seem to be on a roll.
Yeah, got four more people. So David.
Thank you. So this is wickedly difficult to get right, a board assurance framework, because it's not just a product, it's a way of thinking and it's a way of being. And you know, we've gone through, it's sort of, it has to knit together threads that we as an ICB don't actually own. So you're trying to bring in the known unknowns. You know there are things that are connected to this, but we can't actually see it. So it's really important to start somewhere, which is what the ambition has been, and to acknowledge the engagement and the development and the progress that we've made in getting it to this point. And now that we have the framework, we can have a better conversation about it. And I think that's the kind of way we've got to in the room. And with Rob, it's really important that we don't keep trying to have a conversation about how we design this. We need to take that outside this room. And what we need to do is bring the conversation to the strategic risks that we've got. And there may be some quality assurance stuff that we need to do to get it here, but just to acknowledge that it's going to take a few iterations to get it just right. So that's my opening comments. The key, more precise comments, I think that it's clear when you see it together like this, the risks aren't the totality of the risks and may not even be the right risks, because we need to be much more strategic about, you know, what are the things getting in the way of us achieving our key ambitions. It's not business as usual stuff. So I think we need to do some work on that, and that's something we need to take outside here. What I do want to check, and we did have this conversation, I think it was in risk and audit, about the risks sitting at 20. I'm really, really uncomfortable with risk sitting at 20, because the impact, we're saying it's very, very likely to happen, and the impact is going to be catastrophic. And that can't, if it's right, then that's fine. But that's the work, that's all the work that we need to do until that risk comes down. Because that would just bring the whole, being dramatic about it, but it could bring the whole system down. So, and that's potentially where we're noticing the disparity, because the risks are so high, but the actions are so BAU, and they just don't tally. So one of the two, or maybe both, aren't right. So I do think, yes, the refinement and the improvement, the constant improvement is really important, but critical importance is the risk scoring 20s, even on the ones we've got for the moment. That does not feel right.
Very helpful. Thank you, John.
I think three things. Maybe if I unpack this, I think we've had some discussion on this at Risk and Audit Committee. And I think, first of all, the risk appetite, to have a board shared risk appetite is really important. And I think we need to look at that on, say, an annual basis. But we have had this conversation that brings together an appetite for the ICB, because each of us as individuals will have our own risk tolerance or risk appetite. But I think it has been important to get to a shared view. But we should have in our wiring the regular review of that, just to calibrate given the circumstance within which we're operating. So I think it's really welcome to see that here. I think then secondly, we get to the actual 5 that are in here. And I do think Stephen, Neil, Dawn, Rob, we need to ask you to take those individual matters and uplift them based on the conversation that we've had. Yeah, because Rob, I think it's right that you make that point. It's not feeling like the document you want to offer us like the fully formed item, but that's what we need to see. We need to see that here. And we did agree at the Audit and Risk Committee that there will be a cycle where we will take each of, at a time through the year, we'll take time to be able to study and understand where we are and are the controls operating in the context of our appetite. So I think that's the second piece. And then I think the third area is, because there's some executive work to go, I do think that then being received in portfolio, and Patricia, your help with this at execs, because then we'll need to be calibrating that when the individual execs do their work, that there is, that it fits together as a suite. So I think those are the 3 areas, and I think those were the actions that we talked about at Audit and Risk Committee.
Thank you very much, John. Debbie.
So mine was +1 to Rob and David's comments, so I won't reiterate those, but I just wanted to remind the board that actually the corporate risk register, which we've been seeing at every board meeting, looks absolutely nothing like it did 12 months ago. Because what we did was we've been using it for 12 months, and every board meeting we discussed, we evolved it, we tweaked it, we made it actually better. And so I think I'm really with my two colleagues in let's actually start using the strategic and let's tweak it as we go, let's evolve it, let's get comments every single meeting, and let's just make it better as we go, rather than keep sort of discussing the format. We need to actually use it as a live document. So just supporting that really.
Thank you. And Patricia, just before I bring you in, one final thing from me, which is, can we really think as we're evolving this about cause and effect? So, so I give the BAF one as an example, that digital maturity. And I think in part it links to the point that David made around the scoring. But we're talking about digital maturity, infrastructure resilience. And then we say, if we don't do these things, it will lead to unsafe services and potentially worsening health inequalities. And I'm not sure that that's the case, actually. We may not be able to do some of the things we want to do. I'm not sure, by not being more mature, that it's going to lead to unsafe services. There might be some other risks that would lead to that. So I think we just really need to think about cause and effect when we get there. Patricia, and then I'll go to Neil.
Can you hear me?
Oh.
Can you hear me in the room?
We have a plan for the break.
No, okay, it's in the chat.
Okay, right, so nothing we can institute now. Unfortunately, we can't do anything now, but I understand we're going to try and get things resolved in the break. So, so we will come back, Patricia, to you on this one. Neil, is there anything you want to say? I mean, you've heard all the comments, so.
Yeah, firstly, a huge thank you. And without meaning to make any pun, thinking about the first session about hydration, I'm a glass half full person, and it's probably a good thing in this context, but all of these are the commentary. Debbie's, I'm going to not go to all the points, but Debbie's point about this is an evolution and things take time. This is really, really important stuff, and it's really good that we're giving it this airing and this time, and thank you for the level of detail, because it's, I think there was also the word gestation was used. This is a difficult pregnancy, I think, and we're not quite there yet, but some specific things. I think the risk scoring, which David picked up, and Jenny, I think you were talking about in terms of the digital one, the risk scoring, of course, and this isn't me passing the buck at all, but the fact is the risks are owned by the owners. And, you know, for example, the digital one, I wouldn't push back. I would discuss, but I wouldn't push back. If the owner of that risk feels that is the risk, then that's, I think it's really important, and we've got to make sure we don't push all the risks too far back, but at the same time being realistic and getting that balance between making sure we don't hide things or feel the pressure to downgrade them a little bit, because I know there's some people, I would include myself in it, that the digital risk absolutely does present a risk to patients. That's not necessarily everyone's view, but I think these risks being real is really, really important, and I wouldn't want any of the risk owners, when we're making sure we're talking about the right risks, and they really are strategic, to feel pressure to downgrade them. But I do think, therefore, the other side of that coin is that the actions, and that's been picked up by a number of people, the actions have to be proportionate to the size of this. So if we really have gone round on this and there is a risk that is up there, then we really do need to make sure that the actions are really proportionate to it. And a number of people brought that up specifically, and I think I'm really grateful for that. The other thing I want to say, there's John's point about we've got to make sure we uplift this to the strategic level. There's a bit of, and it's not in this group, there's a bit of regression to the mean. So we have these conversations and then we go back and look at it, and sort of something pulls it back away from that. And so I go right back to Siobhan's point, right at the top. This doesn't feel, and I've got that same discomfort. This doesn't look patient-centered. It doesn't feel, when we read it, although all the points are valid, it doesn't feel like where we want to be and the big, bold steps we've got to be. It does keep coming back to something that feels more like a corporate risk register. And I think that, for me, is one of the things I've really heard, and really got to lift that. And that's it's interesting why that is such a challenge across the system and all the people that contribute to this. And I think Rob's point is really well taken. This isn't what it's meant to feel like. So the comments that we got, the way of thinking, this is meant to represent the culture. The biggest risk to our transformation is the culture change, is that we change our shift to prevention, to being patient-centred, and we put the things in place. And we haven't captured that yet in the document. And the comments we've had today at every level, and Dan, your offer for help will be and is, and Rhiannon gratefully received, because we're still working on this. So all these comments have been heard. I don't think there's anything that anyone here would disagree with. So using this to iterate the next version is going to be very useful. And I look forward to the opportunity to work between this, but then to bring it back. So thank you.
So you'll need to think about what you'll need to do, because it will be back next month, won't it, or next meeting. So I think there's quite a bit that needs to be done. But Dan, just to close this off, you wanted to come in?
I kind of just wanted to put a challenge back to us all, not just the exec, because I think there's two conversations going on here. I absolutely agree with that. Please can we stop talking about the design and format of the document and use it and iterate it? And Debbie's point was really well made about how much the corporate risk register has come on. I think we've just had a strategic risk conversation because of the document. I don't think we've had an assurance conversation because of the document. And I'm fine to be told that I'm wrong, that a strategic risk register and a bathroom is changeable. I don't think they are. And that for me is the bit that I just want to make sure is clearly on the table, because that's how we'll have a bath conversation rather than a risk and action conversation.
Yeah. Your offered help has been accepted, so we'll leave it to move forward. Now, Stephen, I know you said that there's plans for the break, but we've got quite a few items prior to the break. It would be helpful to at least hear the chief executive's voice on them. And I know, David, you're presenting the producer's report, but I wonder if there's anything we can do now to see if we can.
So we'll need the 15 minutes.
We'll need the 15 minutes. People will be happy to do that, and then it'll be quite a while before we have lunch, but yeah. Okay, so we're going to take a break now. So just for everybody online, if you want to log off for 15 minutes, if you rejoin at 11:15, and let's see if we can get the IT sorted. Thank you. Let's hope the guys still around.
Sorry, that's too loud.
No, it didn't happen yet. It might have been
Trying to get these two. I'm going to do yeah.
It feels like that.
So we've got Holly. Yeah, but I don't think.
is obviously there, and hopefully everyone's had an opportunity to read it. So I'm not going to go through it line by line or anything. I'll just pull out some key highlights that I wanted to share with the board. So section 2.1 just presents the challenge that we continue to have around waiting list access for Tier 4 services. This isn't a Dorset issue, this is a national issue, but it does pose a significant challenge for our providers who are continuing to accommodate young people in our acute wards, which isn't the right place for either the individual themselves, but also for the other patients around, so and for the staff. So we continue to observe this. We continue to have discussions at our SQG around how best to manage this. At the moment, the NHS and local authority partners are working together through our agreed memorandum of understanding framework, and working really well together to try and manage the risk of harm and wider impact of this. But we are awaiting the revised Tier 4 specification from NHS England, and so not quite sure when that is coming out. It is due, so hopefully we might have a bit of an update at the next board meeting on that. We had a deep dive at SQD on follow-up to patients that were awaiting this. All of our providers are really being as proactive as they can to try and actually find the best ways to actually follow up patients that are waiting longer than we'd like on our waiting list. Again, patients are waiting longer nationally post-pandemic, and anything we can do to actually minimise any harm to patients whilst they're waiting is obviously really important. So we had a really good deep dive with regards to that at our SQG meeting, sorry, System Quality Group, I should say, meeting. The other deep dive that we did at our System Quality Group meeting was in relation to reducing the risk of harm associated with our no criteria to reside patients. We know that we still have higher numbers of no criteria to reside patients than we want to in Dorset. We are making progress. I'm looking across at Dean and Siobhan. We are making progress, but nevertheless, we've still got more work to do. And we still know that we've got patients that are on our wards that are longer than they should be. And obviously we know that the risk of deconditioning and deteriorating as a result of being on wards when they don't really need to be there is quite high. So providers, as you can see in the report, are actually all proactively doing work to actually manage and mitigate that risk as far as possible, to reduce harm, which is the most important outcome. We have now established our system quality impact assessments group. We're having a weekly meeting. So this is important, as we know we've discussed at board many times our challenging financial position in Dorset, and each of our providers and all of our system partners are having to make really difficult, quite hard decisions as a result of that. It's really important that we put a system lens on that, so that not to have a system approach to sign off quality impact and the quality impact assessments, because that will still need to be done within each organisation itself, but so that we have a system lens on those decisions, and we can actually make sure that one decision made in one provider isn't going to have a negative impact in another, so that we can actually sort of discuss and have those discussions across the system and not on an organisational basis individually. So that is now established. We've got a weekly meeting, and we're just waiting for our first QIAs to come through to that. But we've been working with our deputies, chief nurses, and our chief nurses to get that rolling forward. 2.6 sets out the SEND inspection that Dorset Council had. I'm pleased to say that it was actually published yesterday. So actually it is now published, and I think Matt may well want to come in on that when I finish updating, just to give a bit of an update on that from Dorset Council's perspective. I don't want to steal his moment, so I'm going to pass that over to Matt, if that's okay. And then the last thing I was going to highlight, because you've got a big update around PSERF, which we've actually implementing really well, I think, in Dorset. But the last thing I was going to say is that we are almost at the point well, actually we are at the point, it's coming out tomorrow, our first iteration of our quality performance and finance integrated report. So it's going to come to me and other exec colleagues as a first draft at the end of this week, and we're expecting it to come through our committee structure next time round in draft form for us to start using it, but also discussing it and making sure it's fit for purpose. So the report will be looking different as we go forward, but at the moment, until we've got that into a state that we're very happy, we'll carry on. We'll carry on. We'll carry on with having separate quality and performance reports and finance reports until we've got to the point where we're happy with our integrated one, gives us the assurance that we need. So that's all I was going to say. I think Matt wanted to come in on this end, and then happy to take any questions about that. Okay.
Thanks very much for that, Debbie. Matt, do you want to come in on this?
Thank you, Jenny. Thank you, Debbie. As people would have seen when they read the report, joint area inspection between Health and Children's Services, and the inspection was published on Tuesday, I think, 14th this week. It's been embargoed because we've got local elections. But obviously very pleased that the outcome leads to a level 1 outcome, which is the highest that you can achieve in that. There was a joint publication put out saying the inspection report states the local area partnership special education needs and/or disability SEND arrangements typically lead to positive experiences and outcomes for children and young people with SEND. Children and people with SEND and their families are placed at the heart of all that leaders do. And I just thank all partners in the system in terms of their contribution to that. It's a good result, and particularly for our children. But it doesn't say that everything's perfect. So our next part of that plan is we have to have the 42 days, I think it is, not so excited. Well, it's 42 days, but 42 days an action plan in order to show how we're continuing to deliver for our children.
That was involved in that and getting that result, and if we can report our thanks from the ICB. Kay, I know you want to come in. Just before I bring you in, Steve, do you want us to test online or not?
Yeah, 2 tickets.
Right, shall I bring Kay in then and come back to you? Kay.
Yeah, I wanted just to congratulate you, Matt, on the result of this. As you know, my background's in education, and I still have a lot of contacts with former colleagues in Dorset, and I've been hearing from a number of them how they feel the whole issues around SEND have improved. And I can speak from on the governing body of Kingston Morwood as well, from the point of view of the feeling that the services in Dorset are really genuinely supporting children with significant need. And just to say congratulations, well done. There's been a real significant improvement over the last 5-6 years since I left headship in 2019, and it really has been a journey which you deserve real credit for, and as does Teresa and her team. So just to say, well done, thank you.
Thank you for mentioning Teresa. Clearly, leadership in that space is not something that I do on a day-to-day basis, and it is a team event, but I will take that back to the team. Thank you.
That's part of, I was one of the people that was interviewed for that, and the inspectors were highly complimentary about Teresa. And I think he does deserve that. So, yeah. Okay, any more questions or comments then on the broader? It doesn't just have to be on SEND, because Debbie gave us quite a big update. So if I go to Rhiannon first and then John.
Yeah, my question isn't on. Oh, sorry. My question isn't on SEND. It was just in relation to the points highlighted around ophthalmology risk. And I can see, or we can see, that some work's been done, but sort of reading it again now, it still leaves the question in terms of how much more can be done to impact on reducing the risk, particularly to high risk areas like the impact of retinopathy and macular degeneration. So I just wondered if there is anything that the ICB itself needs to think about in terms of supporting, obviously the constraints financially, because some of the solution has been investing more last year. So I just wondered how that's all going to play out really with the constraints that we're working with, and obviously this is identified as an area of concern really, isn't it?
Debbie, before you respond, I'll bring John in, but I think we've had some progress because I can actually see the room in a different way to how we saw it earlier. So, Patricia, try please. Fingers crossed. Say something.
Hello? Hello?
Are you on mute?
Nope.
Oh,
God. No, we can hear
okay.
you
Well, we're
online.
not getting any loud noises anymore. You've just gone totally silent.
Well,
Right.
we might just have a board meeting of our own. Oh!
Okay, so I'll go to John, and then Debbie, you might want to respond, but I think we've got normal proceedings, so thank you very much, Stephen. John.
Debbie, thank you. It was a question on another topic. It was about PSER. I'm thinking about the assurance we get because the training is complete. It's now in transition mode. I think the paper spoke to the task and finish group having concluded. Is the governance now in operation for PSER across the system? And I would like, we talked about it here, we're going to get some update and assurance at the end of Q1. I'm just checking really that we're on track with the adoption and moving into the PSER integrated approach.
Okay, Debbie, do you want to pick both of those up?
Yes, so with regards to ophthalmology, it was a deep dive. Further work, it hasn't concluded. The deep dive and the further work working through the waiting list continues not only at Dorset County but also across our providers. That's the whole point of discussing it at the system quality group so that we can actually share work that's being done. It is a challenge. I think the backlog for ophthalmology patients is greater than most specialties because the vast quantity of volume that actually goes through ophthalmology was going to have a greater impact from the pandemic than other services, which is why it was prioritised as the first piece of work to be done by Dorset County. Yeah, but so share your concern. They're doing everything they can to actually triage and make sure that that no harm has come to light. We will be monitoring through our incident process if there is any harm, and obviously share any learning as a result of that. But I don't know that I can give you much more assurance than that because it is a risk. It's a risk area, and it's a risk area not just at Dorset but across country, and I feel comfortable that we are doing all that we can to try and mitigate that from a trust perspective. With regards to PSER, absolutely. Absolutely. The task and finish group has now stopped because actually we are fully established as we should be, but we still have our system-wide safety meetings, and we will be getting our regular PSERF and safety, patient safety updates through our quality experience and I always forget what the new term is, quality and safety committee, quality experience and safety, isn't it? Committee is through that. So we get a formal report through that committee and then up to board, and obviously we'll escalate if we need to at all. So, but yeah.
Thank you. Thank you. And I should have said right at the beginning, actually, just to remind everyone, particularly for this part of the meeting where we are meeting in public, to try not to use acronyms. Please use a longhand. And I wasn't aware that Nick was in the room earlier, who's the new leader for Dorset Council. So I think moving forward we'll need to do that because I'm sure it will sound like double Dutch to him at the moment. But certainly for the time that we're in public, we can just use longhand. I think that'll be really helpful so we can keep public with us. Okay, thank you very much then. So we're going to go back to the CEO report. David, you're going to present that on behalf of Patricia.
Yes, although we appear to have sorted out the sound recording just in time, but I'll lead off on it anyway. So I wanted to pull out some key messages from this report. There's some key recent developments that kind of, I think it's really striking. It's just sometimes happens this way, that lots of things emerge and happen and publish at the same time. And some of these things kind of sit at the heart of our purpose and opportunity as an ICB and as an ICS, and relating to our key ambitions and our wider operational, financial quality and sustainability obligations. So we've got in the report, you'll see an update on the CAS review. So John is going to pull that forward a little bit, but it's just really important that the full report to come out in April, but there was an interim report that came out in 2022 to just about 2 years ago is that the system, NHS England and others have been working on changes, and they're starting to be implemented. And as the report goes on to say, there are ambitions to have 8 regional centres to work and release the benefits of working at scale, but also to make sure there's support and access into local services. Now, we're really, really keen that this happens and we get access to that across Dorset. So we are engaging with that work, but it's still in its early stages. And as we've noted, there's only 2 of the 8 centres so far launched. So at least there's some access to some service. Well, 1 in the Northwest and 1 in London, but there are plans to roll that out in each of the regions. And there are a couple of things also around the Health Inequalities 2040 report, as mentioned in 2.2, and the Tobacco and Vapes Bill in 2.1. I think they are vital developments that we really need to pay attention to, because it's going to take all partner action to try and address those things. And I think it's perhaps fitting that we're here today in the Bournemouth, Christchurch and Poole Council offices when actually to highlight these 2 things when those are matters for everybody to pay attention to. So colleagues, if you haven't had a chance to have a look at the Health Inequalities report, it's well worth a read. The GP contract, this is so important for us to pay attention to. You might be aware that the national baseline uplift for the GP contract this year was at 1.9%, when inflationary uplifts in other sectors have been between 3 and 5%, and in some cases above 5%. And given the importance of our general practice provision in the health services particularly, it's a very striking difference, he says, choosing his words carefully. And as a consequence of that, the BMA ran a referendum with its members to do a temperature check of the feelings amongst its GP membership. And 99% of those members voted to reject the contract offer in theory. So that's led to quite a significant number of conversations at a national level. I need to stress that that's not a strike vote. It's a test of ambition or intent or disquiet, I suppose, amongst the GP members, and that's leading to high-level conversations with NHS England and ministers around what happens to the future of this. I think we can expect this to come back and unfold over the rest of the year as that kind of, for want of a better word, that dispute unfolds between the national system and GP members. Locally, of course, we're working very closely with our GP practices and PCNs to support their resilience in the face of unprecedented demand. And we have to acknowledge that our GP practices are responding massively. I think it's about 78,000 extra appointments they've offered over the last 12 months in relation to that demand, without any increase in GP numbers, or indeed, as you've just noted, that without massive increase in funding as well. It's a really, really challenging environment, and I think it's important the board acknowledges that, but also recognises that we're working alongside general practice to try and support that. And key to it will be the rollout and the development, the accelerated development of our integrated neighbourhood team model, which is our out-of-hospital model across Dorset, and that's later on in the report. I was going to highlight the SEND report because it's sitting in here. So just to give you another shout out to the SEND partnership in the Dorset Council area. And I'll actually want to also take the chance to talk about the work going on around SEND recovery, the contrast of that in BCP. We held a SEND Health Summit earlier this week, actually, in this building, which was an important milestone in that recovery work. And what was really powerful and hope-giving was that there are clearly some green shoots in the turnaround work. There have been notable material increases in access, in reductions in waiting times, and the number of people getting access to care earlier has been increasing steadily over the last few months. So the work we're putting in is starting to bite a little bit. There's a huge amount of work to do. I don't want to oversell that, but I do want to give cause for optimism, because I think that's the word. When I left that session, there was real optimism that something has shifted. We know what those some things are, by the way. There's the work and there's the partnership and there's the relationships. We've been through some tough bits, and we've stuck together, and we've got a really credible plan that can keep achieving. And optimism that in the next 3 to 5 years, BCP can achieve excellence. And I would say 6 months ago, nobody thought that was possible. Just getting to okay was the sum total of that ambition. And now we feel, hang on a minute, we've got something here, maybe we can. So I think that was really powerful. So we can learn from the Dorset Council partnership experience in BCP, but just to sort of reassure colleagues that we will be close to BCP to try and make sure we're doing our bit and supporting our partners in that delivery. And of course, I can't go on without mentioning the operating plan and the recovery work. This will appear through the course of the meeting, so I'm not intending to go through the detail of that, but I do want to highlight how hard and diligently our system leaders and teams have worked to properly balance our duty to the taxpayer with the health and wellbeing contract that we've made with our whole Dorset population. You'll see in 5.2 the priorities that we've set out for the coming year. They are intended to balance those two key responsibilities. Can we pay some attention to the improvement transformation work that we need, whilst making sure that we pay attention to productivity, good due diligence around the money, and making savings where we can and where we need to. And there was a national meeting referenced in 4.2, and that has now taken place. That took place on Tuesday. Other colleagues may wish to speak to it, but the outcome of it was really good. The meeting went well, and we have reached agreement with the regional and national team on our financial and operating plans for this year. And that in itself, I think, reflects the strength of the partnership and the strength of the work behind it. A couple of final points. I was conscious when I was going through this that certainly when I've been covering this for the last 2 or 3 times, that I tend to focus, and we tend to focus on the cross-organisational issues, because usually they're informed by national or regional or local developments, and it's just about tying the things together. And notwithstanding that, because that is really important, I didn't want to lose the opportunity to flag again the partner updates that sit in Appendix 1. And as I was going through this to try and pull out highlights, I made a note on a few of them. I thought, oh no, there's too many. I'm going to be talking forever. So I thought, well, okay, I'll just do a summary of it. So if you haven't had a chance to dip into that in the detail, please do. It's really good. And finally, I've often quoted Myron Rogers, who I've worked with in the past, and Myron is an internationally renowned change agent, and I like the way he thinks and the way he works. And one of his maxims is that the process you use to get to the future is the future you get. And judging by the work and developments over the last few months, the future for the whole Dorset system, I think, looks really promising indeed. So I want to inject that sense of hope and optimism into it, because it's been a really, really tough few weeks, but a really, really good week. And this board meeting and this particular item couldn't come at a better time. So thank you, everybody. I'm happy to take comments, questions.
Thank you. Before we go to questions, Patricia, did you want to add anything?
Don't know if I can follow that. Well, first of all, it is my first public board meeting, so I think it's right that I acknowledge David's leadership of the team and the partnership working that has got us to a really good place in terms of nailing down the details of the operating plan and giving the right level of assurance to NHS England around our ability to deliver, which I think led to a very brief conversation on Tuesday around the plan, and some really positive feedback for us as a system around the level of partnership that had been developed that had got us to the place that we're at. The only other things I would add is that we also had a visit yesterday from the Chief Delivery Officer at NHS England, and accompanied by Adam Doyle, who's the National Director for Integration, and the feedback yesterday was incredibly positive. Partly because we have got a good plan, but also because we had the clinical lead from our respiratory network across Dorset presenting on how he has used the information available from our DICE system to change the way that respiratory teams operate, particularly in the space of secondary prevention. And as a result, over the last 4 years, they have halved the mortality rate for some of our really key respiratory conditions. And that was really wonderful to see yesterday, the impact of a different way of working and how spreading and scaling that across the rest of our services can make a really substantial difference to the outcomes for our community. And also they were incredibly complimentary of Forbes's leadership of the Primary Care Alliance and the grip of the strategic issues and the detailed actions that are needed to address them. So really supportive of David's point around the work that we need to do to support primary care to be sustainable. And whilst there is the national conversation happening, recognising that there is a lot for us to do in that space that can really make a difference outside the national contract negotiations. I think the challenge that Adam and Steve gave to us yesterday, which I think was really helpful in crystallising our thinking around the fact that we've got a number of things that we need to, from a governance perspective, keep a grip on this year and next year that are going to be the catalyst for the changes that we've committed to for our Dorset population around population health and the things that we really need to deliver now, because we need to do what we've said we'll do. And I think in terms of those challenges, yes, we've got to deliver operating framework. Yes, we've got to deliver on the corporate priorities that we've agreed. And we have a very strong system governance process in order to do that and hold each other to account. But if we're going to really set the foundations for the change of the future, then having an equal focus and governance around the out of hospital work that David talked about, which is centred around the integrated neighbourhood teams, the new hospitals programme, which for the largest part is the acute transformation within Dorset, and some work at Dorset Healthcare that enhances mental health services, but also makes some changes in community to contribute to that out of hospital model. And how that will drive the change of delivery in our system that starts to bring down the cost of healthcare, but also then increase healthy life expectancy and healthy life years. And then thirdly, our population health approach and how we really embed that into all parts of our system so that we're not just looking at health services, we're also working through the ICP on the wider determinants, and we as health partners are maximising our ability as anchor institutions to contribute to that agenda. So I think there's work for us to do around the governance around that to be able to evidence to the board that that twin track of work is happening and that it's delivering the results that we've committed to.
Thank you, Patricia. And I was also going to ask Forbes whether or not you wanted to come in for two reasons. One was picking up on the meeting that we had yesterday, the visit we had yesterday. One of the additional comments that was made was recognising the assets that the CCG had actually left for the ICB, which has put us on a really good start. So to have greater recognition on that. The second thing was also one of the parts that David picked up in Patricia's report around the phenomenal increase in GP appointments that you and your colleagues have been doing across Dorset. Yet we still hear that people say they can't get a GP appointment. And so I was going to ask either you or Ben if there was anything more you think we as an ICB can be doing to kind of manage those messages. So, but Forbes, do you want to come in?
All right, thanks, Jenny, and thanks to David and Patricia for the comments, which are comprehensive and helpful. They're very important. The future of primary care is hugely important. We heard it yesterday. Primary care is the foundation, and if there's no primary care, we don't really have a health service. And the concern for that is growing all the time. And this is why, when we have seen such an increase in productivity and engagement, particularly in Dorset, and I have to absolutely commend my colleagues across the whole primary care system for doing that. to then nationally get this contract offer is a real smack in the mouth, quite honestly. And this is about paying our staff. So we're totally dependent on our workforce. Our workforce see headlines of expectations for pay increases awarded in other health sectors, and then the offer to general practice is much, much less than anywhere else, yet they feel they're being increasingly productive, and the evidence supports that. So how nationally they could expect that to play out well or just be accepted is beyond me personally, but it's not my decision. So therefore, we have now got a situation where instead of people looking forward, which is what we want to create and want to encourage, particularly in Dorset, there's this frustration and quite frankly anger that nationally there's just no recognition, quite frankly, of the work going on in the health system, but particularly in the out of hospital health system. And then to get this barrage of media attention and political messaging about, you know, we're going to do what we can to make sure you can get an appointment with your GP is just, unfortunately, missing the point. So that needs to be addressed, and the BMA is obviously taking steps to try and address it, and let's hope it can be addressed, because I don't know anyone in general practice who wants to go and strike, and it'd be a real, quite frankly, moral dilemma for many people. But, you know, we have to say that people feel stronger than ever about it. And I know there's all sorts of options being discussed, which I'm not party to within the BMA. That being said, you know, what we've got to do is to do what we can locally. So back to, you know, the project that we've been undertaking, the Creating Sustainable General Practice project and the 10 themes in that. What we've got to do is try and look to see what we can do locally to deliver those, quite frankly. The meeting yesterday was helpful. The message came back, there's no new money, so therefore the responsibility again rests with us to see what we can do within our own communities in Dorset. After the general practice session yesterday, we had a session on the neighbourhood teams, and you know how strongly we are committed to making that happen. And I think if there's something the ICB can do to help, is make sure we apportion resource, and financially probably not that much, but a degree of human resource to make sure we've got project support to move this forward. I keep saying it's part of the solution. It is not the solution in itself, but it will certainly help some of the challenges that we've got. And why would we not look at the best use of our resource that we have across the system in Dorset? So, you know, we'll continue to do what we can. We'll continue to meet regularly to try and look at maximise the opportunities that exist. But it would be nice to have some help nationally. It would be quite nice, and I'm afraid there seems to be a tension. One, there's the financial issue, we get that, but actually they could be sending some positive messages in some other areas and not just waiting for an election, which is what seems to be the case. And that therefore stifles any progress. And quite frankly, we don't have time to wait. Things will get worse before they get better unless we do something.
Okay. All right, thank you, Forbes, for that. So we're going to go to questions and comments. I think you indicated, Rhiannon, did you? So I'll take you first.
Yeah, thanks. So, like I said, yeah, it was just a sort of tangential comment, I suppose, or are we aware of any potential risk that could arise? So this is in relation not directly to the CAS review, but the announcements that were in the news this morning about the change of curriculum for children and young people at primary care age, and particularly they were highlighting not discussing things like gender identity, etc. And I was just wondering, you know, whether there could be potential risk in terms of where those families might then need to seek support, advice, perhaps from health primary care. So it's not one really for now, but it's just being alert, I suppose, to is there a potential risk that could fall out of in this area?
I guess, yeah, it's probably not one for now, but I guess this is this is definitely a discussion with local government as well as education, ICB, around how we move forward on those things. But
Yes, we've obviously heard the announcements this week and just waiting to get the detail. I mean, the clarity is that schools are responsible for their policies around this, and it's if the government is able to give clear direction, that will help schools around that. But I think, as the previous speaker had said, clearly that might be a policy decision. That might then lead to a vacuum for information and advice and support for children and their families in this space. But as local authorities, we're not local education authorities. We don't run schools in that sense anymore, but we do support schools in terms of provision of support. So it's important we get that right and that we stay within the Equality Act and we stay within the guidance given by government.
Yeah, I mean, listening to Gillian Keegan last night, she was really clear that services should be provided, but it's not the place of schools to do that. So that's what I was thinking about, that all the thing picking up on this point. So I've got Siobhan and then Debbie.
Thank you. I just actually bearing in mind Forbes and the last sort of presentation, I just wonder whether, in terms of our risks, priorities and priorities for the remainder of the year, whether we should be explicit about supporting the sustainability of primary care within Dorset. I just think it's such a big issue this year that maybe as an ICB we just need to be really explicit that that is a priority for us all. And then also, I would say this, but the changes around acute care and the acute pathways, Patricia, you mentioned it, which was good, but I think actually having it as the priority within Dorset over the next year or two, because it is across all the providers actually in terms of those acute pathway changes, and it is linked to enabling the future that we're all trying to create around the 5 pillars. We're also trying to strengthen the provider collaborative in Dorset over this year, and I sort of think it probably should be explicit. And then finally, just for good news, we, after Tuesday's meeting, UHD received their letter of approval for the FBC yesterday. So that is the FBC for the new hospitals programme.
Thank you. That's good news, actually.
That's very good news.
Yeah, definitely. Debbie.
I was just going to come in on a positive, because it's always good to draw out the positives and not just the challenges. And I think sort of in your report, Patricia and David, your presentation, you said about the work done on the tobacco and reducing smoking. And I think sort of we heard Sam, actually, our Director of Public Health, presenting on that yesterday. And I think the progress we've made on reducing our smoking across Dorset, we've still got work to do, but the progress we made is actually really, really positive. And I think particularly wanted to say something about UHD and the work that you're actually doing and the progress you're making within the hospital, that actually Dorset County Hospital are actually sort of going to share the work that you've done so that we can actually sort of progress quicker. So I think it was just, for me, it just demonstrated that when we all put our heads together and we all work together on a preventative option, we actually can do really well. So I think it's really important that we've chosen 3 prevention priorities still, even with the pressures going forward into next year. And so I just wanted to say that.
Thank you, David. And then I'll come to Kate. Do you want to come in?
Yeah.
I'll let David just respond on that first.
Well, it was to Siobhan's point around GP sustainability. I think it's, given the nature of the conversation we've had, I thought it was really important to clarify and expand that it is in the priorities. That's how, through the integrated neighbourhood teams is how we're going to get there. Taking Forbes' point, absolutely, but it is not the sole answer to everything we need to do. It's just one of the key important steps that will help us. So if it's going to help send the right signals out into the system, maybe we add a bit of narrative or a few words just to make sure we draw that connection for people so they don't see it as 2 separate things. But for the record, it is the same thing. So that's what we're going to achieve it through.
Okay, I think you wanted to come in on the same point, didn't you?
Yeah, well, I was just going to say that one of the things I was going to report from the Prevention Committee is that we're currently drafting a risk around GP sustainability, and that will be added to the risk register very soon.
Okay, thank you, Dan. Then I'm going to move us on.
Can I just ask about comms out of this? And the thing that made me think about it was the main operating base for South West ambulances. I think most of the population would really welcome that news and would kind of understand what it means to them in terms of a tangible kind of service-based, and Siobhan's news about the Future Hospital Programme. So how do we consider what we put out and when and to what channels for the population? Because there's some real good news here for the people who pay the taxes to receive services. And so how do we consider that? And then how do those comms go out? Which is a really broad question. So I guess I'm just looking for some assurance that we do consider those things and do what's appropriate.
Just sure, David, do you want me to respond quickly to that?
Well, I can say a bit, and then I think Dawn probably would like to come in because she's the exec lead for comms and engagement. So I meet with Kirsty, our head of communications and engagement, every week, and we have a discussion around what type of things we really want to be putting out there as messages, and how that then translates into the blog that I do on a Friday and any corporate messages that go into that. I think the conversation we've had more recently is, aside from the normal communications activity that we would do either to the public or our staff, or when new developments come along, the fact that we want to start to put out an ICS comms brochure maybe once every couple of months with some really key developments and results that are going on across the entire system. So Kirsty's just thinking through now what the format of that might be. Obviously, it's got to be written in accessible language. We also don't want it to be too long because otherwise nobody's going to read it. And so it's got to be quite punchy. And how do we then make an assessment every few weeks about what the key messages are that we want to get out to all of our staff across the ICS, as well as maybe putting something out in the public domain?
Thank you, Dawn. Did you want to add anything to that?
Patricia,
yeah,
sums that up really. Thank you.
Yeah, thank you. So a few things out of that discussion: the sustainability of primary care, which okay, you might come back on anyway, but we know we've got in hand. Resources, a real plea from Forbes there about the resources to the integrated teams. Similarly, recognition around the provider collaboratives that we're doing. And for us to note our congratulations to all that's been involved in the UHD new hospital programme, and that the FPC has been signed off. So well done for that. Okay, so that takes us then to the finance update, and Rob, I'm going to go straight to you.
Thanks, Jenny. So we're running over.
We are.
And this is really just to confirm where we finished the position last year. We probably want to have a longer conversation around the plan. So just to remind you in the personal points, we had an expectation from the national team that we'd finish with a 12.3 million deficit. Previously, we talked to the board about actually we were sort of a bit stuck at 19.9 million, so still quite away from that 12.3. We actually ended the year at 14.6 million deficit as a system. What did we do to get there? Well, actually, we'd had some assumptions for some benefits to come through around some coding changes around the elective recovery fund. At the time, they were being rejected. We couldn't find a way through that. But actually, quite late in the day, some of those were then accepted and agreed. So we didn't really change anything operationally. We were just we were given a bit more funding basically through the elective recovery fund, based on some sort we'd already made previously that then came true. So it was good to get to £14.6 million. That was accepted by the national team. They pushed hard for us to get to 12.3, but they also recognised that we were sort of around that 19.9 million. So 14.6 has landed well with the national team. So that's a good outcome. In terms of what's important to realise, though, to get to that number, we had to do an awful lot of non-recurrent things. We need to get better at the recurrent savings, and that will come through in the plan, because delivering that number with the non-recurrent effectively means that you have a higher starting point for the following year. If we deliver them recurrently, then we'd be in a better position moving into the year. Now, we know the reasons around that. We've talked about before, about the strike action, all those sorts of things. In terms of the large areas for growth, and hoping you're well versed in these now, but I will tell you them again anyway. So you know that within the ICB, our personal health commissioning, we had a flat cash budget on that one effectively. that actually ended up £35 million over that. We were £14 million over on agency across our system partners. We were £7 million over on prescribing. And then we also had a fair bit of non-delivery of the cost improvement plans in the providers as well. So just under 15 million in UHD and 6 million in Dorset County. In terms of capital, because we don't often talk about capital, we ended up with a slight underspend on capital. That's predominantly there was a £4 million slippage with some ambulance, delayed ambulance spend effectively in SWAS. So that's needing to be fixed for next year as well in discussion with the national team around that. So that's why we had a small capital underspend. So that was the position. In terms of the ICB was actually 17.4 million in deficit. Dorset Healthcare had a small surplus of 2.8 million, and Dorset County and UHD were both at break even. So that was how the positions landed. All subject to audit. We're going through the audit now. We're not expecting any issues around audits. I don't think there's any issues in our provider colleagues either. As well, it should be hopefully quite straightforward. Okay.
That's it. Okay. So questions, comments? Okay, I'm going to move us on then to the SIS's performance report. Well, there's no questions. So. Brilliant. Similarly, this is about the close of the year, isn't it? And also the 23-24 years. So, so I'll hand over to you.
Thank you very much. You'll see the report. I think you mentioned in the introduction, Jenny, kind of the improvement that we've seen in performance during the year and the really positive position that we have ended the year in. We submitted a operating plan, a really ambitious operating plan at the beginning of the year. We saw some of the operating standards, some around mental health, some around kind of the 4-hour emergency standard kind of being really challenging during the year. We have brought just about all of those back during the year. Out of the 35 standards that we're expected to meet, 19 we achieved. There are 9 further that are improving. And there are only 7 that are deteriorating, 2 of which are on the kind of first order list of priorities. The first one of those is the utilisation of our virtual wards, and the second one is on the 4-hour standard. But I think what I must stress, I think, on the 4-hour standard is the significant improvement that we saw during March in the recovery of that, and that is down to the work both at Dorset County Hospital, who have been above the standard for the whole of the year, and also the significant improvements that we've seen at Bournemouth and Paul through University Hospitals Dorset's improvement. You achieved a position of over 70% for March. That has further increased during April as well. So we're starting the year better than the position that we expected to be in, so the trajectory that we put in for the first part of the year. And I think because we are now, we are 6 weeks into the new year, just a few headlines on where we are with the month 1 position of this year. We're making really good progress, so 65 weeks. We are on target for kind of the number of long waiters that we've got. Category 2 response times for ambulances, we are much better than the standard. We're delivering 23 minutes for the category 2 response times against the 30 minutes expectation nationally. Ambulance handover rates are really low within Dorset. We're doing that within 24 minutes as an average compared to what we're expected to do at 40 minutes. No criteria to resign, still a big challenge for us, but we are better than our trajectory that we put in for the year. So we're improving that. And I've mentioned A&E as well. There's 2 areas that I wanted to pull out where we're again not where we want to be. Dementia diagnosis rates is going to be a challenge for us this year. We are wanting to improve that performance from 55% where we ended the year up to 66%. Now, to do that, we have got to review the whole of the dementia pathway because we can't do it by doing what we've always done. So there's a significant improvement that we've got to do there. And virtual wards, there's still been some improvement, but there is still a lot more to do. our occupancy rate, so we're wanting that to get up to 80% utilisation, and we're at 76% for April, which is a big improvement on where we were in March. So there's really encouraging signs, not just for the end of last year, but for the year coming on. So I kind of recommend to you kind of the significance that we're seeing in our performance.
Thank you very much, Jean. And in terms of the year that we're in now, where we're going, we can look a bit more on that later when we go into part 2, because we've got the plans there. But are there any questions or comments either on the report or what Dean's put in for the year that ended? So Lisa, to you.
Thank you. First off, congratulations, well done. I mean, it's really easy to read that, isn't it, and completely underestimate the peaks and the troughs and the hard work and the steep climbs that you've had to do. So let's not underestimate. Let's just acknowledge that it's been a tough year and well done getting to where you are. You talked a bit about it when you talked about dementia. You talked a bit about, look, there's only so much we can get to. There's only so much improvement we can achieve through incremental improvement before we have to start having conversations about this isn't working and we have to do something completely different. I know it's not binary, it's either incremental improvement or doing something completely different, but I'm going to kind of treat it like that in this question and say, where do you think that line is as we move forward? How much of what we do can we improve and get to a good standard through incremental improvement? And how much of what we do is just going to be that sticky residual stuff where we go, actually, doesn't matter how much we try and improve incrementally, it's just the way we do it that is wrong, and we've got to change the way we do it. Are you getting a sense of that balance as we move forward?
So I think two things I'd say in response to that. First of all, when you look at it by PCN, so primary care network, we have a massive variation in the dementia diagnosis rate. At the lower end, we've got 42% dementia diagnosis rate. At the upper end, 80%. So it's really different. And what the programme of work is early on in this year is to do a deep dive into those to understand why we have got such a variation in it. And I think what really backs up why I say that we need to really look at the whole pathway is because during last year, we invested another 160,000 in capacity so that we could see more people. We didn't end up with any more people being diagnosed with dementia. Now, that is not going to be because there aren't people with dementia, given the population that we have got. There is something else at play there. So I think we've got to do those two things, look at it in a more localised level, what is working in some areas and not in others, and just putting extra capacity in with the existing service didn't deliver during this year.
Thank you, Dan.
And so to echo what Lisa said, I've not seen you deliver that report with a smile on your face before, Dean. So, but to kind of say thanks and acknowledge all the work that's gone across performance and finance, because across the whole system. Kind of this conversation, this might be part 2 question, so maybe you park it, but it reminds me of the BAF and where is there work that we do on how we outturn 23-24 with the assumptions that underpin 24-25 to bridge them, to reconcile them, because I think that'll be a really good source of assurance about this is where we ended the year financially performancely, and therefore what we assume for the 24-25 plan. And it might be something that the board gives to P&P, it might be we do somewhere else, but there's a kind of reconciliation here between the BAF, where we've outturned financially, non-financially, and what we planned that we're in the first quarter into. And I think that'll be a rich source of assurance about where we'll land this year.
So can I suggest that we think about that when we get into part 2 this afternoon, and think about how we want to respond to that. So I'm going to move us on to the committee escalation reports, and I'm going to ask all of the chairs if you can be brief, because we are running quite a bit behind now. Because I assume people have read the reports. Of course, we've got a couple of things where we have got things to escalate here to the board. So you might want to dwell on that for the committee chairs that have got that. But other than that, if you could keep it brief. So we're going to go first to Cecilia for the ICP escalation report.
Thank you. I just would, to be brief, yes, we had a great opportunity where partners were able to actually provide us a review of what they thought was going well and what their challenges were. And I think we again, the ICP is getting to a stage now where it is a very mature board and partnership. And I think you can see there the priorities that we've laid out, which should be recognised by you all and be aligned with the work that's going on. I will say that having listened to the hydration conversation earlier on and listening to all the work that we're doing on smoking and things, I think the partnership, is a place where we can help amplify some of the messages and some of the work that's that started at the ICB to make sure that it does get rolled out across businesses and across communities. I think the ICP partnership is where some of that work could happen. In support of obviously other activities that are going on there. And I would say the comment that Patricia made earlier on about trying to increase comms around the work that's going on. Oftentimes, I'm very privileged to be able to see what's going on and to be able to read about it in these meetings. A lot of partners don't know all of the good work that's going on, and it's difficult for them to feel that the things are as positive as are described in here. So the opportunity to do more around comms, I think, would actually help both the ICB, the ICP, and the system as a whole. So thank you.
Thank you very much, Cecilia. Any questions or comments? Okay, let's move on to Productivity and Performance Committee. Dan.
I just take it as read that the main bit of work is around PHC and how we assure ourselves that we're on track in year, especially considering prior year outturn in this year's budget. That's a performance and quality conversation, and then looking at what levers the ICS might have to pull if we see ourselves coming off track, and that's an iterative piece of work that the committee will be doing and has been doing. I wouldn't pull out anything else.
Thank you very much, Dan. Any questions or comments? Okay, to Lisa then for the People, Engagement and Culture Committee.
So no significant issues for escalation, so I'll also be brief. The work plan is a work in progress, but the revised committee work plan was approved.
Oh, Mike, sorry.
Sorry. No significant issues. The work plan was approved. We're revising that. It's a work in progress. So we had the approval of the first iteration of that. I'm going to pull out two things, I think. One is the ICS Workforce Productivity Report. Productivity is an issue and we need to get a grip on it. And so that is going to be in the spotlight now. It's coming back to these committees and we are going to continue to look at it and scrutinise it quite robustly. And I think the second thing kind of linked to that, but it's around workforce availability, is that we are thinking about, and we have actually created a risk for the corporate risk register around recruiting, retaining, and the impact of vacancy gaps on workforce for our staff. So that's pretty much all.
Thank you. Any questions or comments? So can we go to Prevention, Equity and Outcomes Committee, which is Kay, and I know you have got something to escalate, haven't you?
Yeah, I have. Just to say that we had a very good presentation and discussion around the Health Inequalities Annual Report, and good progress is being made on a Health Inequalities dashboard, which I think is something really to be commended. The two areas that we had particular concern with regard to escalating, one of course is the one I've already mentioned, which is risk being drafted about the sustainability of primary care. And the second is around dental, which I don't think will become a surprise to anyone given the issues we had when we originally took over dental. But there are a number of areas around dental and a number of serious concerns which will be escalated to the board in July. And also there will be a consideration of a risk being added to the register relating to dental access and oral health.
Thank you very much, Kay. Any questions or comments? Gillian.
Really helpful to see the escalation coming on dentistry and that will be coming in July. I know that that's an issue of concern in the BCP area and I know across Dorset generally. I wanted to check that that's going to be an all-age piece of work and it's going to look at children's dentistry, not especially, but equally.
No, it will be all age, with particular reference to children in a number of areas, but it will particularly children care, which is going to be one of the key priorities. But the access issues, one of the problems is a lot of the issues about dental access is outside our control because it's to do with the dental contract. But as far as we can mitigate those, we want to make sure that we are looking to those and that we are recognising the significant issues in both dental access and also prevention with regard to oral health.
Thank you.
Thank you for that. We know dentistry is a really big thorny issue, access to NHS dentists. And it's probably the top thing that I get communication on from our MPs. So,
sure.
So I think there'll be a lot of interest in that. I think the other thing in your escalation report, you picked up a theme that we had earlier today, which was around risk and assurance.
Yeah, I didn't mention that because it had been covered before.
Piece will also come through. So thank you very much for that. And then the Quality, Experience and Safety Committee, Rhiannon.
Yeah, thank you. Obviously take it as read as well. But just to probably pull out, there was, I'd say, quite an energetic discussion around the whole issue of Tier 4 children, adolescent mental health services, to the point that we have asked for a deep dive to understand some of the risks around that better, and obviously the importance of having children in the right setting, irrespective of what they're seeking to have their health needs met on. I think the other thing we did, there was quite a detailed conversation around the SEND improvement plan, and obviously David has referred to that in the Chief Executive report. But I think just to say, I think what was heartening to hear is that collective responsibility that I was hearing, or we were hearing in the committee, in relation to creating the right conditions to drive that improvement plan. And I think the only other thing to say, there was some feedback around the clinical plan implementation plan, just to further strengthen, and obviously the role that the committee can play in oversight of seeing that working its way through. Thanks. And no escalation.
Thank you. Any questions or comments? Okay, so let's go to Risk and Audit Committee and John.
Good afternoon. So nothing to escalate from the Risk and Audit Committee. We had a preview conversation, I think, earlier on around the risk register and board assurance framework. So we spent time formally reviewing those and actually approving the corporate risk register as normally we would do at the Audit Committee. We covered a lot of business, which is covered in the report. I suppose the key thing that followed on from the Productivity Committee is we received an update on the key management judgments that are part of the year-end accounts. And we talked a lot about the process by which we'll take our year-end annual report and accounts through the assurance cycle into the next Audit Committee that will be next month. So those are the key updates from the Audit Committee.
Thank you very much. Any questions or comments? And then finally, but by no means least, the Strategic Outcomes Committee. Sorry, Strategic Objectives Committee. I didn't have my paper there. And Kay.
Yeah, we had nothing to escalate significantly, and a number of things that we discussed at this committee are actually on the agenda today or have already been discussed with regard to the BAF, for example. I think I would like to say that we had a very, very good discussion around the new digital strategy, and I'd like to thank Stephen and his team for that work, because it was fascinating and really interesting in the committee to see that one developing. But we have also approved in principle a risk relating to the implementation of the EHR, the electronic health record, for the corporate risk register, given the issues that could very well develop in that area.
Okay, thank you. Any questions or comments? Thank you. Right, so let's move on then. So this next item is for decision, and it's the People Engagement Committee work plan. So Dawn, if I go to you first, please.
Thank you, Jenny. So I'm very pleased to bring the annual work plan for the People Engagement and Culture Committee to board today for approval, having been through the committee itself, recognising, of course, that this will continue to iterate and respond to the needs of our system. So a couple of key points to note. The committee held a development workshop at the end of March to define priorities for 24-25 and also agreed to a set of design principles. One of the principles was working with other committees, notably performance and productivity, around workforce productivity and the fact that this is such a key issue this year and will be considerably strengthened by working across both committees, with both committees having a focus on this. The targets agreed in the NHS operating plan mean that we need to strengthen the ICB role as a regulator and for insurance, and the PC work plan reflects this. It also, the aim was to keep this as light as possible, with space to be able to flex to the deep dives needed to the system. I'm not totally sure we've managed to achieve that, and so this is part of the ongoing testing that we are bringing what's absolutely relevant to move this this agenda forward. Happy to take comments, questions.
Okay, so Kate.
Thank you for this. I absolutely agree with the phrase there was to move away from oversight and assurance of programmes and plans to oversight and assurance of priorities and outcomes. Absolutely. A number of your outcomes will be very long term, and I know this is an annual plan, but I wondered if there were ways that you were thinking of putting in some kind of measurable impact, you know, as to see how we're going along the journey, because it's very easy to have long-term plans that slip if you don't have some kind of measurable impacts, and those impacts being more than just the actions have been completed, but actually properly what differences are we seeing because of that, and if those milestones are going to be added to your planning.
Yes, of course, and Kay, spot on. That the work of the committee needs to balance between the sustainability of our system and the financial recovery and the part that we play in that. Those outcomes and impact are much easier to grip. The longer term stuff, there is, I recognise the danger to move to nebulous impact in the reporting, and the team are cited on this. In fact, there is a workshop on just this stuff taking place the week after next. Thank you.
Debbie.
Thank you. Thanks for this, Dawn. Just one small thing for me. I just wonder on your work plan where you've got the corporate risk register coming to each meeting. I just wonder, and I don't think this is unique to you, I just think following the discussion around the BAF, whether we should actually have the strategic risks also coming to each of the committees to have committee discussion about it, so that it's not just the chief officer's input into it. So I just wonder whether that bit should say corporate risk register and strategic risks to come into each committee for discussion.
And that's a good spot, Debbie, because it's on the agenda for the people Engagement and Culture Committee next week, and it did. I also spotted that it hadn't made it onto the work plan, so thank you.
Anything else? Just one from me then, if I may, which is so the name of this committee is the People Engagement and Culture Committee, isn't it? The work plan, though, just seems to pick up the people and culture, and in fact it's called People and Culture Committee. The engagement bit seems to have dropped off on the work plan. And then apart from the I think there's annual reports that you were proposing, I didn't really see anything else around the engagement, but one of your key priorities was to engage with communities. So I wanted to understand how you saw that happening and how is that going to live through the annual plan of the committee then, the work plan of the committee. And I don't know who best to put that to. Maybe both Dawn and Lisa want to respond to that.
I'm happy to take that first, Jenny. And at our development workshop, we considered how to integrate the work of communications, engagement and people into our strategic and operational priorities. So rather than separating and reviewing in silo this work, to bring it together and show the threads. So if I take an example here, under the strategic and the strategy and transformation elements of the work plan, in the integrated neighbourhood team item there, you'll notice community engagement and workforce development. So within that report, the committee can expect to see both the community engagement side of the integrated neighbourhood teams and also what that is leading to around the workforce development, because the community engagement supports the development of the services within integrated neighbourhood teams. It also tells us what the workforce developments are that need to come out of that and the different workforce models and ways of working. So the integration of engagement and workforce and communications is integral. And your comments make me think that if that's not being if that's not having the impact that it needs to have, my suggestion would be that we test this in the committee and take feedback as to if it's working in the committee, and if it isn't, then we address that.
So can I just ask a bit more on that? So have you got in mind how you see that engagement happening? So is it an evolution, for example, of the 100 voices, or is it something else? Or is the detail around that still to be done?
The 100 voices in the communication is how we do engagement. That is our approach. So everything that we take forward is through that mechanism. That's our vehicle for ongoing community engagement. We won't be describing what community conversations and 100 voices is. We'll be doing it and reporting on the impact of that.
Okay, thank you.
Siobhan. I just wonder, just from my perspective, Patricia and I have had some conversations about actually how we work on some more detailed communication strategy as a sort of as Dorset, as we continue to make the changes around the integrated teams, but also in the hospital pathways. So I think there probably is a little bit for us to consider. There is a sort of comms and engagement strategy and plan, but I'm probably talking from a lens of providers, but actually how we as a system engage our public in that will probably be really important.
And Siobhan, to that point, absolutely concur. So the communication and engagement steering group, their work plan and their progress comes through the committee. That communication plan for the implementation of the CSR and UHD's transformation is one of the small numbers of focus for that for that subgroup this year. So I would see that work coming up through the committee. And back to the point about having some space there, if the committee feel that that what's preferable is a deep dive into that work, then absolutely we can bring that back. That is very much part of the subgroup's work plan.
Thank you very much, Lisa.
I think there are two different things here. I think one is communications, which has come up a couple of times now. Dan raised it earlier, and that tells me that we probably do need to take that as something for a little bit more exploration. I think that the important thing with communications is to be really clear about what we're communicating, why, and who to. So I'm always quite wary of very broad, nebulous communication conversations, but I'm always really welcome, as does the steering group, conversations on what are the key messages and how do we communicate them and who. Right. So I think that's a really valid question, and I think it is something that we should pick up. But I think the broader question for me is, and it comes back to what Dawn said, if it's not obvious that these things are in hand here, then we'll need to test it and make sure that they are in hand. And it's a kind of the conversation that we had with the BAF as well earlier on, is we're going to get stuck in and do this and see if it works, but that will require discipline. And I guess for me, my assurance to you is there are a number of things that aren't explicit here but are implicit. One is yes, we will constantly, to everyone who presents at this committee, be saying a couple of things. One, and how are you going to measure success in a way that we know either a milestone towards the end game or the end game itself that is measurable and smart, and we know whether or not it's working. And the second thing is, and how much is that going to cost? Because what are we paying for what we're getting, and is this the best way of achieving it? So those are the things that aren't obvious here, but there is a discipline we will build into the way that the committee works to make sure that that happens. And I think it's important for me to give you that assurance, and Dawn as well, that the behaviours and the culture of that committee will maintain that discipline and will drive that discipline through the way that.
So that's, sorry, go on, Neil.
No,
I'll come in after.
I just wanted to pick up on Lisa's point and say that, and we're coming on to this afternoon, but one of the key roles of the, thank you very much, flashing green.
Why is yours green? Oh, it's on now.
Thank you. Just wanted to pick up on Lisa's point, and we mentioned it this afternoon, but one of the key points of the strategic portfolio management approach is that everything ultimately will be measured, specific, smart outcomes, and the costs of the process. Those will be set up in advance for everyone to see and reported up, and then they will be monitored. So it's not that every individual team is going to have to set up this process, that we have standard, systematized approach to measure the outcomes, to monitor the benefits, and to assess the risks. So I think that will address that point, because it's common to so many committees.
Thank you, that's helpful. I guess my question was more around the engagement as opposed to the communication. And we had a method for that engagement as we started, didn't we, which was the 100 voices. And we know that there are plans to evolve that to 10,000, 100,000, whatever the number is. I'm not sure how that is docking back into us as an ICB, whether that's coming through you or coming through something else. But maybe if that's something you can think about, because I think there is something about keeping the ICB on board with that evolution and that development. And that might be what you're meaning about the engagement pieces on there, that you now have ownership or oversight of that piece of work.
Yes, I do. And the communication and engagement steering group is the place that embeds that.
Great. Thank you very much. Sorry.
Yeah, and I think also just another step from that, following on from the 100 voices, is obviously with the emergence and development of PCSA as well of the Assembly, and the growth in that, and again coming back to the funding position as well. Now that is now a CIC as well, into that we can actually get other funding for other things. So I think also with the voluntary sector and the charity sector, that will be emerging in time to expand to a much wider audience, and it can be on the back of work that group are doing as well.
Yeah, I think there's certainly a role for that group in the BCS Assembly and moving that forward. There's also a commissioning conversation and our commissioning response to the BCS Assembly, and the comms and engagement and the commissioning functions work really closely together to drive that forward with the Assembly.
Yeah, it's the commissioning side. Yes, I totally get that, because obviously we're still not finalised, but it's beyond that, because we're talking about, you've been talking about 12 months and you've been talking about longer term. So I think from a longer term point of view, as that becomes more embedded, there will be different opportunities externally from the NHS funding. So to actually support what's happening in the neighbourhoods and all that sort of thing, and the hubs and the community hubs and everything else that's going on. So I just think it's got to be thought about a bit broader than just purely NHS commissioning on this, and how it develops. And this should be embedded in our plans as well, to make sure that we are embedded in your plans and that we are working from one and singing from the same hymn sheet, basically. So that's what I was trying to say. So it was just, now that we've got this partnership, it's just, this is another opportunity where we could expand for the future and move forward with it.
So you're talking about making sure that things are synchronised, and that we keep, I guess, the thought around that going over time, not just the short term, but the medium and long term.
Yeah, because it was been alluded to earlier, that
Yeah.
this was a 12-month plan, but actually there are certain things that we can highlight and move forward for aspirations for the future. I just wanted to make sure that this side was in.
So I'm going to encourage you to keep that discussion going with Lisa and Dawn. Patricia.
Just in response to Zoe's point, John Sloper is deeply embedded in the work we're doing around the Overton Hospital neighbourhood model, and is working round not just our community groups but other VCSE partners to make sure that the process we're following in the short, medium term and long term embeds that sort of core design approach, and also the longer term partnership that's always talking about. So I think it's really valuable to have John in that space and to continue to move that forward together with us.
Thank you very much. So this paper, this work plan, is here for approval. So can I just seek the board's approval to the work plan? Thank you very much. That's approved. So that then leads us on to the equality delivery system and equality objectives. And Dawn, I think this is here for us to understand what work is going on there and how those objectives are moving forward. I think you've got Fran here as well. So afternoon.
Thank you, Jenny. So so this is Fran's here to talk through a presentation on the action to meet the ICB's quality objectives, and this follows a report to Board Part 2 in March, and is designed to bring to life for the board in public the a summary of the work that is happening in this space. So I'll hand Fran over. Hand over to Fran. I won't hand Fran over.
Hang over.
And I think we've got Anita also joining us online, who's instrumental in this work. Hi, Anita. Okay, Fran, over to you.
Thank you. Hi, good afternoon, everyone. Yeah, so I'm Francesca Pingrelli. I'm the head of OD for NHS Dorset ICB. And as Dawn said, we are bringing a brief kind of highlight presentation just to cover off some of the work that's gone on already, where we are, some of the sort of outcomes and therefore targets and measurables that we're looking to try and achieve as an organisation, and then the plans that we've got in place to achieve those and how we're going to measure them as we go on. So just to kind of link that in. So the presentation, if you just go to the next slide. Broadly, we've got our new and refreshed equality, equity and diversity and inclusion plan, and that's combinated from the things that we've done and we continue to do and take into the next year, the metrics that we have and where we are and the insights that we've got, and then what we're planning on doing next. And as an organisation, we've taken the opportunity to not just look at workforce equality and diversity and inclusion, but bring it together to also look at the population equality, diversity and inclusion. So we do them hand in glove. And some of that is, in terms of our plans, is demonstrated as we go through. Some of our plans as well are also, just to notice, whilst this isn't an ICB, NHS Dorset Equality and Diversity Inclusion Plan, we work with our partners across the system. So some of the actions are very much system focused and with our partners. So there is a crossover there. So we'll explain that as we go through. So I'm just going to hand over to Anita, that's going to start us off, and Anita can introduce herself. And talk about some of the things that we've achieved so far.
Hi,
thank you.
Thanks very much. I'm Anita Council. I'm Deputy Director of Health Inequalities and Population Health Management at the ICB. And as Fran mentioned, we work closely together because our equality duties for patients, for staff, and as a leadership role are intertwined with one another. We've talked before to the board about our overarching equality duties, and that's how we, and our equality objectives, how we demonstrate we're meeting those equality duties. So this presentation is focusing on some particular actions we take around an NHS England process called the Equality Delivery System, which is one of the ways in which we meet our equality duties. So we go into the next slide, please. So I'm going to focus in on equality delivery system objective 1, which is around services, and Fran will talk a little bit about workforce and leadership later. As part of that objective 1, NHS England invites ICBs and in fact other NHS bodies to take a deep dive into 3 service areas. In doing that this year, what we wanted to do is actually not just think about the 3 service areas and leave it at that, but take it as an opportunity to look at how our general processes for quality improvement and for population health outcomes embed action on equality. So as part of that, if you just go to the next slide, please, we used our population health management process to have a real deep dive into how we're capturing information, how we're meeting our quality duties. So the first thing that we did was look at, see if we could find 2 of those really good subjects to scrutinise. So 2 pieces of work we looked at. One was around falls risk modelling. So that was quite a technical piece of work to understand, could we look at population data and find out who was more likely to have a fall before they'd had the first fall and therefore intervene earlier. And in using that's one of our equality delivery system reviews, we wanted to check back and see whether or not we were inadvertently not considering variation, not considering different population groups' risk factors around protected characteristics. So those are the factors such as age, gender, race, and so on. So we looked back at all the work that had been done, all the technical aspects of it, and determined that actually when you broke it down, you could see that different protected characteristics were information on those is collected, were being considered. And in fact, 2 of those, age and gender, were independent risk factors for predicting a fall, and those were captured adequately in the process. So we thought that overall, the process in relation to the falls risk modelling, we had to consider our equality duties. There was some wider learning came out of that, and that's that we shouldn't be resting on our laurels. The particular review found that we met our duties, but actually we would need to individually consider for each of the services that came out to address increased risk. They independently would need to consider potential variation between the different population groups, particularly thinking about the needs of different age groups and different genders and different preferences of different communities. And alongside that, although we were able to assure ourselves that lots of information had been collected on different protected characteristics, one of the findings was, and this was something that we already know and work started on, is that our ethnicity recording in services is often very poor. And actually we're not really able to detect true difference because we don't know which ethnic groups people come from, and therefore we can't scrutinise it adequately. So a wider finding was improving our ethnicity data collection. Similarly, the other deep dive we did was our end-of-life care services, and a hugely comprehensive piece of work had been undertaken as part of population health management programme to inform a new end-of-life care strategy. And again, we looked at all that piece of work that included comprehensive engagement with different service user groups, included a particular equality impact assessment, and we could see where different protected characteristic groups had been considered. And therefore, in the PHM process itself, that seemed to be picking up our equality duties. Again, a wider finding was that although we'd engaged with lots of groups, what we weren't able to do is break down that engagement by protected characteristic. So we couldn't see, although we could see lots of different voices had been captured, we couldn't differentiate between voices, so who had said what and was there any difference. Alongside that, there was an overarching finding, a part of that wider piece of work, that actually there's more to do on patient experience and more to learn about patient experience overall. And as part of that, a work programme's been instigated where a doctor calls everyone who, the families of people who have died in Dorset, to find out more, to get some more rich qualitative information about the end-of-life care experience. And the next step for a quality review will be to really scrutinise that end-of-life care experience, richer data by protected characteristic, so we can see are the different voices coming out that indicate to us that we may need to do different things to support people who share a protected characteristic compared with those that don't. That might be age group, ethnicity, it could be gender, a whole range of factors. But that next stage will give us richer data on that variation piece. Similarly, we also found that information on ethnicity was not as well captured as we'd like it to be. And that means that in our next equality objectives, we'll have a cross-cutting piece of work on that to rapidly improve our data collection for ethnicity. And that's a major priority for us. So overall, we found that for our PHM pieces of work, they were embedding equality, consideration of equality duties within those. What we want to do now is systematise that. So we found that they were, but we didn't have a specific process within PHM that said this is where we're capturing that information. So we're now adding that to our PHM processes so that whenever we do a PHM piece of work, we're automatically doing an equality and inequalities deep dive, and that will build our collection repository of knowledge and learning over time. And those pieces of work are not only captured through our equality work streams and through this committee, through the People Committee, but also through our Prevention, Equity and Outcomes Committee. And I'll talk a little bit more about how that sits in a wider health and equalities piece of work later. Our third deep dive then was led by University Hospitals Dorset, and worked together as a system on all of these to understand where frontline services might be more likely to have patients who don't attend their healthcare appointment. The first part of that was UHG looked across the services and to see where they were experiencing higher rates of DNA. And they found that ear, nose and throat services had some of the highest rates of patients who didn't attend or weren't brought to their appointment. When they scrutinised that further by protected characteristic, they found that in particular, children and young people were less likely to be brought to their ENT appointment. So that was the first finding of this stage of their equality review. The next stage is doing a 100-day process to understand the reasons for that, and then to do that improvement piece of work to tackle those barriers. And the learning from that won't just apply to ENT, but will form a suite of resources that we have available to help us to scrutinise appropriately all of our services, to understand why people aren't being brought or don't attend their appointment, and to address the barriers to that. Because we know that oftentimes where we have variation in services, it's not because services themselves are not inviting people to an appointment or doing something different to pick out different groups. It's because people are less able to engage with our service offer. And we want to design out inequalities in that, and design out differences by protected characteristic group from the beginning. And these three pieces of work will help us on that. An overarching piece of work around services will sit as part of the work that goes to Prevention, Equity and Outcomes Committee. So that's a quick summary of the deep dives that we did this year, with a particular focus on helping us to understand how we can embed this in all of our work to improve outcomes for patients. We will, of course, be doing 3 more of these next year in partnership with our system partners, and over time that repository of learning will be spread out and shared. I'm going to hand that back over to Fran now to talk a bit more about leadership and workforce elements of our equality delivery system work.
Thanks, Anita. Yeah, if you could skip a couple. Sorry, Jane. So turning to some of the things that we've achieved this year, notable things, and what we'll continue to do, all organisations around the table have staff networks. We've done quite a lot of work to embed our staff networks across the organisation, and also starting to look to work across the system and bring our staff voices from our networks together, because I think we all think there's real opportunity in doing that. We just thought there's a very short interview with our EDI lead from the organisation and our newest network chair from the Ethnic Community Network, just talking about some of the links between her role and the impact that can be made as a network chair in the organisation. Okay, thanks, Jane. Shared with sound.
Apologies, that's not coming through.
Sometimes you just need to share with sound when you're, it's like a little dial thing. It's a shame not to hear one of those. So yeah, we've got 3 networks at the moment. So we've got the LGBTQ+ network, Pro-Ability network, and as I say, the newest network is the Ethnic Community Staff Network as well. And we've actually got senior leaders that support each of those networks as well, and have been supporting the work that they do. Hopefully, this should share the sound.
So that sound's not coming through at the moment.
Now I'm looking to Stephen.
On the red box at the top, is it, it's got the drop down. Does that give you the option there?
No.
Have we got Stephen?
No, that one is embedded into the package.
Yeah, if you want to use online.
Yeah. Was there anything else that you wanted to say? If you carry on. And then
Yeah,
hopefully we'll
okay.
get-
So the other element that we wanted just to update on is that we've last year we jointly commissioned, or the ICB jointly commissioned a programme across the system for circa 20 leaders from across the system to join a programme called the Leading for Health Equity and Inclusion programme. And it just finished yesterday. So we had, we've gone through the programme over 9 months, and we've had leaders from across the system, including police, GP surgeries, we've had from social care, our local authorities, etc. And it all culminated in yesterday, them sort of doing some deep work around what the impact has been on that programme. And it feels like actually, although that's the end of the programme, it's really just the beginning of the journey, because there was quite a lot of feeling in the room around the opportunity now of that group and the understanding that actually the power sits with them in terms of being change agents, and linking into the work that Anita was talking about and some of the health inequalities work across the system and our broader equality work with regards to staff. There's a real appetite and energy that we need, it's quite palpable, that we need to capitalise on. So we've also got a video that summarises that, which I can show you shortly after. Hopefully this one now will also work with the
Hi, I'm Sapna Vora, EDI business partner for NHS Dorset. We have Rebecca Sultana here with us. I'll let Rebecca introduce herself.
Hi, my name is Rebecca Sultana. I'm Project Support Officer for the Population Health Management Team, and I'm also Chair of the Ethnic Community Staff Network.
Thanks, Rebecca. Tell us something more about your role as a chair and how it complements your full-time role.
So my role as chair synergises with my position in the Population Health Management Team, enabling me to contribute effectively to our mission of promoting health and inclusion, equity and improving health outcomes for all. By fostering inclusivity within our organisation, I'm better equipped to advocate for health equity and address health inequalities within the communities we serve.
Thank you. Clearly, there is a lot of overlap within your role as a chair and your full-time role. So what future opportunities are there for you as a staff network chair to develop yourself?
There are several opportunities to make positive impact within the organisation. Examples are leadership and influence, professional and personal development, networking and collaboration, influencing with decision making, support and empowerment, and addressing local concerns.
Thank you. Thanks, and all the very best.
Thank you.
Just move on now to the next video. Is a video that was taken yesterday, some short clips of some of the participants on the programme I just described, just giving a summary of the impacts that the programme's had.
So I've been taking part in the Leading for Inclusion programme over the past few months. It's been really great getting to know so many people from across the system within the group and within the programme. I think for me what's been really important is actually through those connections that I've made through the programme and elsewhere throughout my work, is I've really been able to kind of view and listen to people and understand a range of people across the system in terms of what's important to them. And one particular example of a piece of work that I'm currently involved in is engaging and listening to the population of people who live on Portland. And this has been a really interesting and exciting piece of work, whereby we've been really hearing and understanding what's important to people. And collectively, with colleagues across the system, we've been able to improve on some of the service delivery and ways of working with the population.
It's clear from me attending this programme that we face a great number of similar challenges, both in the ICS and in policing, and that key to solving those challenges is us committing to continuing to collaborate in such a positive way.
So the Leading for Inclusion course has had a really big impact for me. I have felt more empowered and confident in my role, and how that has played out in work is that I'm able to move into that facilitated space. I'm sitting back more, not feeling pressured to provide the answers. And in turn, I've seen my colleagues and leadership move into that collective ownership space for change and really think about how together we can empower ourselves to lead change with inclusion.
So I've been on the Leading for Inclusion programme, and one of the things that's taught me is to really seek out people and help them to move forward with their work. So a recent example has been with a medical team. So I've really spent some time with the team to feel and learn and understand what their pressures are within the team, and for them to express with their patients how they can change the way that they provide services. That's led to us coming up with a different strategy for the team. And at the end of that, the consultant and others were really thankful for having the opportunity to listen and express themselves in a way that they feel they've struggled to do over the past few years.
So as a result of this programme, the one thing that I really noticed is that change starts within, and it's reinforced to me that it's not necessarily what you know, it's not necessarily what you do, it's about how you make people feel. And by recognising that in myself, I really thought about how I can use that inner reflections to liberate others to be able to recognise the value that they bring. And whilst there's probably examples of things that have happened and influenced in work, the one thing that I've actually done differently and that I wouldn't have done as a result of this programme is I've taken the leap and I've signed up to be a young person's and care leader's mentor, recognising that actually I can hopefully use my own self-reflection and added value to help individuals reach their own potential.
Hi, I'm Liz. I've been part of the Leading for Inclusion Dorset Change Agents programme, and collectively at the end of the course we were given a very open brief to sum up what the course has meant to us all and how we've changed. We've created a poem called Change Starts With Us. Change starts with us, that's the honest truth, sharing wisdom from the days of our youth. Responsibility is what we share, building connections and showing we care. By networking, we achieve new heights. Our words and actions add new insights. Be more human, that's what we ask. Be your true self, get rid of the mask. Challenge and empower, lift each other high. Share the vision and let your stories fly. Don't be afraid to say what you feel. In our Dorset, inclusion is real. From city streets to rural plains, we are all in this, there is no one to blame. Together we rise, united we stand. In the face of adversity, we expand.
Thank you. Just move on to the next slide. I think that sums up really well the where the programme got to and the kind of energy in terms of expand of what's next. And there is next. So only this morning I've been on one of the workshops that we've jointly designed and are jointly delivering across the system around conscious inclusion and inclusive leadership. So I've left it in the capable hands of our colleagues from Dorset Healthcare that are carrying on the rest of the session today. And these are just short, sharp, half-day sessions open to the whole of our system. We have people from primary care there this morning, and it's carrying on some of the messages from that wider programme about how change does start with leaders and the impact that they can have on creating the right conditions for equity and inclusion in their teams, and then how that then creates better population equity, health outcomes, designing and delivering of services in a better way. And already the people that have come on the programme, we've only had sort of 2 workshops. The outcomes actually have been brilliant. They've said we need to get our teams along to this. This should be mandatory. Everybody should be coming. It's really powerful stuff, and it's really starting to shift the way people think. And so I think the more that we can do more of this and create a bit of the social movement around how it feels, we should start to see the impact on the outcomes and the metrics. Because when we go into the next paper, we'll see that is one of the areas in the staff survey that just doesn't seem to be shifting as much as we would like it to be. So if we can just move on there. So that's kind of a deep dive into some of the things we're doing and have done and are continuing to do. In terms of data of where we are now around workforce for our organisation, if you just move to that next slide, thanks. These are a couple of just headlines. I mean, they look quite stark when you see them there like this. These are the ones that are kind of the ones that we want to investigate more. There's probably some variation in there, but these are some of the ICB NHS Dorset equality and diversity and inclusion metrics from the staff survey that we really need to get underneath the skin of. So we'll be working with our staff networks to really understand what some of these things mean, because the staff survey is just a point in time. And from these metrics where we know there's the biggest disparity and differences and therefore potential inequity, we've then designed our outcome measures. So if you just skip to the next slide, for the first time I've been in these types of roles, we've got some really quite ambitious, I think, targets around workforce and improving some of those metrics. And I've heard it sort of, because I came in earlier, I heard some of the discussions. We won't just be waiting until the next staff survey to see have we made the difference. Yes, that'll be our point in time measure, but we are going to use pulse surveys quarterly and ask specific questions around these areas. And also we're going to use our quarterly listening events with our networks and with our staff forums to ask questions around what does it feel like, and what are some of the things that are working so we can do more of that, what are some of the things that aren't quite working so we can test and adjust as we go along. I think that should be a really good approach that we should use in staff engagement in our organisation as we go through. If we just skip to the next slide, please. Hand to Anita quickly.
Thanks, Fran. Yeah, I just wanted to flag at the end that, of course, our equality work isn't a standalone piece of work. It's part of a wider programme to address health inequalities, because we know that the reasons why people experience differences in variation, unwarranted variation, unfair variation in access to our experience and outcomes from services are multifaceted. And the more risk factors you have, the more chance you have of having poor access and outcomes. So we've got an integrated programme. We are developing an indicator suite, and we will have lovely dials like Fran had before to measure our progress on the work. Some of that will be things that we can measure in years. Some of it might take 20 years to measure true outcome, such as the gap in health and life expectancy. But what we're doing is building across a system, a multifactorial work programme where each partner is bringing its strengths, talents, opportunities and working together on those things. So anything from the training that our staff need, and we've heard about the powerfulness of having an emotional connection with the work through our leadership training. So an overarching skills, knowledge, ability training programme across the system to a real focus in on prevention and aligning our preventative activity, primary, secondary, tertiary, all the different aspects of prevention to helping people to, when they get a problem, be able to live well with it. Growing our strong communities, making sure our data is right and we're collecting what we need to do, analysing it, and really focusing in on our services. So what happens when people get to services? So we'll have a cross-cutting programme reported through our Prevention, Equity and Outcome Committee and up to our Systems Executive Group to help us to navigate the complex pathway to addressing those differences in health outcomes, including those that are associated with some particular characteristic groups compared with others. I won't go into detail on the next slide. It is a bit of an eye test when I look back at it in terms of being able to read things on a slide, but that tells you a snapshot of some of the kinds of things that programme will be focusing in on. And this year will be a rapid programme of development and delivery for that, and drawing on the skills and talents of those people that came through that leadership training that Fran's talked us through a moment ago. And they're absolutely chomping at the bit to get involved in, within their own organisations, work to address differences in outcomes for their population groups, who of course are the same population groups as we in the ICB have. So I think I'm going to hand back to Fran now for my canter through some of the top line things that we're doing as part of the wider health inequalities programme.
Yeah, I think in the interest of time,
the end, because I'm conscious.
Yeah.
Okay, so
the action plan is at the end as well, in terms of the activities that we're going to take forward in the new objectives. All of that's on our new NHS Dorset ICB website, and they're all aligned to addressing and the targets that we've made. So yeah, open to any questions.
Thank you very much. So thank you to both of you. Questions or comments? Obviously quite a lot of work going on there, isn't there? So Gillian.
Yeah, thank you. Great presentation and lots of really inspiring stuff going on. So thank you for it. I wanted to draw out a connection that I don't see in the papers, but I know is being made elsewhere, and just make sure that those dots are being joined for everyone. And in the Integrated Neighbourhoods programme work, one of the outcomes that we are talking about setting for those integrated neighbourhoods is about staff wellbeing, because the idea being that the sort of roles that staff are carrying out in those integrated neighbourhood teams ought to promote that workforce wellbeing and workforce motivation, and that in itself will further the outcomes that we have for communities. So it's just to sort of highlight that and make sure that we're drawing it back into this programme of work as well. So it's a kind of virtuous circle. And then I had a question about the leadership programme. You said it's open to staff across the system. Is that open to partners in the system as well, like local authorities, or is it? Yes, it is. Yeah, that's brilliant news. Thank you. I'll take that away.
So Patricia, I've also got Rhiannon and Dan. Do you want to come in now, or shall I bring you in after? I think you're frozen, so I'll bring you in after. You're unfrozen. Do you want to come in now or after?
No. You.
Okay, you keep freezing now. So if I go Rhiannon and Dan.
Thanks. Thank you both. Really important to hear the sort of more experiential side of things, and it really brings it to life. But actually the importance of the data in terms of impact, and you got some of that in the area that you were talking about, Fran. And Anita, when you talked about those long-term goals, which are obviously hard to see sooner, it will still be really important to have progress impacts in terms of measurable impacts. So just looking, I suppose, for assurance that that will be the case. And just one other question, really. When we talk about children and young people who don't get to their appointments, we say, you know, we don't call them do not attend, do we? We say was not brought. Is that also attributed to people of adult age who are reliant on others to bring them? So is that applied in the same way? So just those 2 points. Thanks.
Dan?
Thank you. Mine was more of an ask, and it's something that I thought when I read the report, and I felt it again as kind of listening to the presentation. So I read the report and was like, clearly there's assured that there's loads of really good and important work going on. I guess the ask is, I really struggled to work out what was for the ICB as a corporate entity and employer, what was for the NHS parts of the system, because that's where I think the 3 deep dives were, and what was for the system, including the non-NHS partners. And I think we're doing bits in all of those buckets, but it's kind of hard to see the sum of the parts without the clarity on what part of the systems we're working on. And so you don't need to respond to that. It's more for when it comes back next time, because that clarity would really help, particularly somebody who's not in it day to day, understand the bits we're doing and therefore the value we're adding. Thank you.
David?
Thank you. It's such an important area of work, and you will have missed it, but at the beginning or earlier on in the meeting, we're talking about the Health Inequalities 2040 report and about the importance of tackling these issues, you know, from the outset and trying to prevent things getting worse. So it's really good to see all this, and you can feel the energy and the passion and the enthusiasm coming through. So thank you for that, and please do keep it up. I have a bit of a challenge because it's to tie into that passion and that ambition. And I was trying to figure out on the workforce outcome targets, and I'm flicking back and forth over several slides, but on the one in our pack, it says that to reduce the ethnically, this is an example, ethnically diverse staff experiencing bullying harassment from other staff. I want to shift the target from 15.8%, the number reporting, and that's in the most recent survey, to 11%. And then on the face of it, I was like, that's a good direction of travel. And yet, if you kind of compare that to staff who, for white background, in the report, it's 3.8%. And I was kind of thinking, oh, okay, so the ambition should probably be 0, that nobody, regardless of background, gets any experience of bullying. But as a minimum, and it's a question because I don't know, should we be aiming for it to be at the same rate before we get to 0, rather than a nudge? And then I was trying to think, well, is that because it's a big issue to tackle, and therefore this is a staging post towards 0? So I was then thinking, well, presentationally, it'd be really helpful to see that. So that's my kind of curiosity. Can we go further I've set a higher or tougher ambition. And if this is part of a considered plan, which is great, can we indicate that we're going to try and get to that ambition, and this is one of the staging posts?
So, Fran, you might want to come back to some of that, and then I'll bring Patricia in. And then Patricia, if I leave you to round off, finish this off. So, Fran, I think you're. I think you're muted.
Yeah, I wasn't going to round off, but I can if you want me to.
If you're happy to, I think that might sort of things, questions also.
No, I think you're spot on, David. It was really difficult actually to try and think of what should be the target, because ethically, putting that in didn't feel right. It felt like it should be zeroed. So it is really, really tricky. I think we went for a 30% reduction, which is realistic given that we're kind of starting the work now and that we're getting the groups in place, and that if we could overachieve on that, then I felt like that would be a good place to be, and then we can readjust next year, because it feels like we haven't done the work yet to say, okay, this is the target, this is what we're going to try and do, we're going to put the mechanisms in place to test and adjust and speak with staff and do the actions, and then see what difference that makes, and then we can see, well, actually, was that under ambitious, and should we put in more of it? So yeah, it's probably slightly under ambitious at the moment, and we could go back and adjust that. I think you might do as we start to talk with our networks and get a feel for it. But yeah, it is a difficult decision to make.
So, sorry, it's that kind of thing. You aim for the moon and you might land amongst the stars. It was just like really sort of go for landing one. Just okay, appreciate that. I get what you're saying actually, because you've got to set this up and then deliver over the year.
Yeah.
Right, Patricia.
Can you hear me?
Yeah.
Good. Right. Okay. So I think my first point would be that I think we need to remember that the equality delivery system update does not fully meet the equality legislation. And we have a responsibility around the equality legislation. So I think it'd be really helpful for the board to understand where those gaps are very clearly and what we're doing about them. I want us to be clear when next time we update to the board that the ask at regional level was for systems and organisations to align their strategy around equality and inclusion to the Southwest strategy. And whilst there are components of it in here, I can't see that direct correlation to make sure that we don't have any gaps. We did talk last year and agree as an ICB that each organisation would agree that we would take a system-wide approach to this. And I'm conscious of the fact there are still local things going on in organisations that are not necessarily being done consistently across the system. So getting a sense of that, particularly in our local authority areas, and what we can do to pull that back to consistency in other areas, not just through the Change Agents programme, I think will be really helpful. Because as we talked about at the time, we have tested over a number of years interventions that actually work. And it would be unhelpful if things were happening that don't work, or we were doing different things in organisations that then we're not all speaking the same language and seeing the same progression of improvement. I'm with David, Fran, I'm afraid. I don't think it's ambitious enough. So I think we need to revisit that, even if we fail on a few things, because it doesn't sit well with me that we think it's all right for 11% of our ethnic minority staff be bullied and harassed. So I think we need to be more ambitious in that space. And then the final thing in my head was I would really like to understand what we're doing with our people teams, because quite often our people teams are the ones that get the least development in EDI and then perpetuate the culture that we don't want to by applying policies in the wrong way. So what are we doing about educating our people teams? And then I was thinking about the national focus on maternity, and a huge part of the focus on maternity, yes, is around lack of compassion, but it's also around variability of outcomes and experience for people depending on the level of dependence, the level of deprivation and ethnicity. So I think it would be really helpful if at some point as a board we had a deep dive into our maternity services across Dorset to see if any of those national themes are appearing in our local service provision, and then agree what we're going to do about it.
Great, thank you, Patricia. I think that's a really good place to end, actually, because I think there's some clear actions there. And I think your first point picked up, Dan's, about the clarity about what's for the ICB, what's for NHS system, etc. So thank you very much, Fran and Anita, for that. Fran, I think you're staying for the next item, aren't you? And you're joined by Tina. I think I saw Tina online. We are now, though, quite short of time. We're meant to be finished in 9 minutes, so I don't know how you want to use this time, but we can shorten lunch. But if you just keep minded to that in terms of your presentation.
Yeah, all I was going to say is that I'll take the paper as read. Good response rates overall. There was good discussion at the People Engagement and Culture Committee about response rates and acknowledgement that they were good and that there was ongoing survey work and engagement work at a local level. The trusts have all increased across the board, in most areas significantly. The ICB has reduced in most areas, but is still one of the highest performing ICB in the country. And so there's trajectory generally of trusts improving and ICBs reducing. And I think the other point to just highlight, and I'll let Tina come in as well with anything that she wants to point out, but the area of least improvement, although there was an improvement, but the areas of least improvement were around ED&I and speaking up. I think the two go hand in hand personally, but so I think there is still work to do across the board in the system on those two areas. But I'll hand over to Tina if she wanted to say anything specifically from the provider collaborative perspective.
It is, I think it's the importance of not only the annual staff survey, but we do also undertake quarterly pulse survey to get that live feedback from staff. And within UHD, we've been using heat maps to at team level, so that we're really clear on what we need to work with those teams to improve. So, but that's the only thing I wanted to add about it being it's a regular review of the results through the year, not just an annual review.
And Tina, do you just want to introduce yourself quickly to everybody?
Sorry, apologies. Yeah, so Tina Ricketts, the Chief People Officer for University Hospitals Dorset.
And welcome to Dorset. Thank you. Okay, so questions, comments? John.
Thank you, Fran. Thank you, Tina. Oh, thank you, Fran. Thank you, Tina. I'm John Bezic. I'm the non-exec who champions freedom to speak up. And one of the things I just wanted to connect to the board, when I saw the first iteration of the paper, I think this was received at the People Committee, I did drop a note because I think we really do need to celebrate when things go well, but we really need to be open with curiosity about what's going on, about the freedom to speak up, of the environment within which people feel they can raise their voice. So I was really keen for us to hear the feedback from the focus groups system-wide about what are some of the insights around that. And I know it's going to go back to People Committee as an update, but I think it's a really important one for us to watch and to really know. So I know you have it in hand, but I just wanted to note that and be keen to hear in a future committee report from the People Committee just about what are some of those key updates. It was really useful to hear the last topic in the context of this paper as well as another one of the focus areas around EDI.
Thank you. Patricia, then, oh, your hand's gone down. Do you not want to come in anymore? Patricia? Okay. Oh, it was a legacy hand, I take it then. Lisa?
This came up at People Committee, but I think it's probably worth reiterating here because what we find sometimes with staff surveys is we'll say, well, that's improved. There's a green arrow up, so that's good. But this is in light of the conversation we've just had, which is what would be really good is if we set ourselves some targets. Where do we want that number to be? Because sometimes even a green arrow up is good, but it might not be good enough. So I think one of the things that we would be really helpful is if we could, instead of just sitting reactively and saying, well, wait to see if it's gone up or down, is set ourselves some ambitious targets on where we want these things to be at the next staff survey. And then when we have a conversation about, is this good or is this not? It's not just about whether it's a green arrow up or a red arrow down. It's about, is this where we should be rather than benchmarking against some average somewhere else. So it's worth saying that setting our aspiration, our ambition for the next survey is going to be really important.
Joel?
Thanks, Jenny, and thanks, Fran. So two points. First point to note, the improved response rate across all of our NHS providers and the improved results across all providers in a year that encompassed not only industrial action, so much change going on at UHD, and also the integration the joint working across Dorset Healthcare and Dorset County really needs to be commended. And I don't think it necessarily comes out as much as it should in this paper. So I think that's to be celebrated. The other thing that not to be celebrated, but really important to note, and I think a really strong step forward in our staff survey, is for the first time we reported on sexual safety at work. And what that does is highlight where we have more work to do. And all organisations are digging deep under what this initial round of survey results is telling us and where we need to go further. And where we need to go further is going to be uncomfortable, because it's bringing out stuff that has previously been hidden, which is the right thing to do. And we need to expect it, just as when we introduced freedom to speak up with the Francis report all those years ago, we will get a surge of people speaking up in this space, which is absolutely the right thing to do. So yeah, that's all I wanted to say. Thank you, Jenny.
Thank you very much. So this is obviously an important item, and I think Lisa's point around ambition is important. I think impact probably also important, because I think we can link to. The question that's going in my mind though is what can we be doing as an ICB to really understand what the type diversity, equality, inclusion agenda is for us as a collective, as a system? Because obviously the NHS staff survey is just the NHS, and Matt and I were having a discussion earlier about the changing makeup of Dorset Council in terms of people that have been elected. So more young people have come onto the council, etc. So it just feels to me we should have an ambition for Dorset, and think about what can we do to kind of measure where we are going in relation to that. Because if you look around our board, we're not particularly diverse, are we? And I know it's a point that John often makes. So, you know, is that one of the things that we would want to change, for example, that we actually look more representative and more diverse to our communities who might come into the room or look at us on screen? So, so I don't know how we do that piece of work, but perhaps, Dawn, if I can leave you to talk to the chief people officers across the system, maybe that's something you can come back to us on at some point. You're going to tell me that you already started doing that work, aren't you?
Well, it's fundamental within our ICS people plan. I think whilst it is fundamental, what it would be good to be clearer on is that Dorset ICS ambition. What does it look like for us? So yes, yeah, happy to do that.
Great. John.
Thank you for flagging that again, Jenny, because I do think it's a really big point. I noticed I should have made the point earlier, and I'm glad you reminded me. In Objective 3 in the previous session, one of the things that there's an objective around inclusive leadership, and it says to create and implement a talent management plan to improve the diversity of executive and senior leadership teams by June 24. But it's silent on us as a board. And I guess I would ask the team to take away, I do think we need to be thinking about us as a board and how we're role modelling this agenda. And for me, I did notice that earlier, but I should have referenced it. We are silent on board composition in that objective, and I don't think we should be silent on it. So perhaps we could just have a look at that point as well.
Thank you. Patricia.
So just to say that I think that's right, Jenny, and there is a lot in the system people plan, but we can do more about that around that subject. But what I would also ask is that if we're going to start thinking about the board being more representative, that we don't just deliver that challenge by having more diverse non-executive directors, because quite frankly, that's the easy step. And in reality, what the NHS is missing is an executive leadership that mirrors the population it serves, because at the end of the day, a lot of the management decisions are left to us. And if we don't have diversity within our teams, so we have diversity of thinking as well as experience, then we're not going to make the right decisions for the population.
Yeah, totally agree. Okay, so let's end that there. Thank you very much. It was for noting, so we've noted and we've had some discussions on that. That takes us to questions from the public. We're probably going to finish probably just over 5 minutes late. There weren't any questions advised in advance, so we won't do that. Any other business? Can I just check really quickly if people have got any other business to add? Okay, so 3 things from me. The first thing is to thank BCP, and if I can do that through you, Gillian, for allowing us to have the meeting here today. It's been certainly an ambition of mine since we started that we don't just sit in at Dorchester in the ICB offices, and it's taken some time to get that done. And I know we were originally going to be here in January, but it's really good that we can be somewhere else in the system. So thank you very much for hosting us today. Second thing is really to say thank you to David, who stepped in and covered as CEO whilst Patricia was off. You know, Patricia already made mention to that earlier, but it was a difficult time to be holding that mantle, and you know, you did it with grace. You took us through. You enabled us to have some really difficult conversations about where we were going to end the year and how we were going to start it. And I know it's not always easy to step up, because then you always have to step back, and you know, part of stepping up is to have some challenging discussions with people that are your colleagues. But you know, you did all of that really well, actually. So I just want to thank you for doing that and taking us through that period. And then the last thing is just to Stephen and the tech team here for working tirelessly to make sure that we can actually hear the people on the screen and that the system worked for that. So, so those were my bits. Of any other business? Just in, I don't know, 40 seconds or so, any reviews of the meeting, anything we want to think about, particularly about being in a different space, whether it's worked. Don't talk about tech because we know we've got that under control, but anything else people want to mention about the meeting? Got any thoughts post the meeting, then please let us know. So that then, I think, concludes the meeting, other than to say that the next meeting will be on Thursday, the 11th of July. I think we will be back in the ICB boardroom, but hopefully one after that we won't be. And that brings the meeting in public to a close.